welcome everyone. We're going to start. I'm Jessica Shore. I'm the Vice President of Clinical Affairs and Quality, and I want to welcome all of you to the Nurse and Allied Health Professionals meeting. We're so happy we're here with all of you in Orlando. It's been 4 years since we've been together in person. Also want to welcome all the new folks who are here. We are so happy to kick off Summit 2023. I first want to acknowledge our planning committee who went ahead and planned the agenda for today. We started over a year ago. I want to talk and introduce Jamie and Janelle in a minute, but they both were on our planning committee, along with Nicole Davis, Lori Reed, Lisa Dykar, Erin Mahoney, and Mary Jamison. So thank you to all of them who planned this great agenda for today. So one call out I wanted to make out before we get into the meat of the agenda is that on Saturday morning, the PFF is going to be hosting a breakfast specifically for veterans. It's Veterans Day, and one of the initiatives that the Care Center Network is interested in really building out over the next couple years is how do we collaborate with Veterans Affairs, the VAs caring for veterans? How do we better support caregivers to veterans and also the providers? And so I just want to let everyone know there is a veterans breakfast that anyone who's interested in attending is able to. It's Sunday morning, and it starts at 6:45. There'll be some programming, but mostly networking. If you have any questions about that, please find me, and I can tell you more about that. So I want to introduce Jamie and Janelle. Jamie Lederer is a nurse practitioner at Penn and has been graciously donating and volunteering her time as one of the co-chairs of the Nurse and Allied Health Network at the PFF for a number of years, and we're so grateful for her. And Janelle, who's a nurse practitioner in research at Kansas. Without them, a lot of our programming wouldn't occur, and so I just want to give everyone have everyone give them a round of applause.
So I'm tasked with going over the diagnostic workup of a patient with interstitial lung disease. And you already heard from Susan about how it's been this kind of year-long course for her to find out exactly what her diagnosis is. I'm sure you've all worked with patients in the clinic that have had a long workup prior to them even getting to you. So we're going to go through the diagnostic workup. It's going to be a quick and brief overview because we don't have all day to talk about it, even though we could talk all day about it. But there will be other talks throughout the course of the conference that will kind of dive deeper into some of these things that I'm going to highlight for you today. So we should probably start with what's interstitial lung disease, right? So interstitial lung disease encompasses over 200 conditions. It's kind of an umbrella term. I often tell my patients when we're in clinic, saying I have interstitial lung disease is like saying I drive a car, but what kind of car do you drive? So it's our job in the clinic to kind of narrow things down and tell patients what kind of car they're driving. So all of these conditions, what do they have in common? They either have inflammation or fibrosis, scarring, in the interstitium, which causes difficulty for the oxygen to diffuse into the bloodstream. It also makes their lungs stiffer so they don't function correctly. So you can see in the top picture, over here, that in a normal alveolar wall, things can kind of move very easily. Oxygen goes to the bloodstream, carbon dioxide comes back to the lungs. But when that wall gets thicker from either inflammation or scarring, it's much harder for oxygen and carbon dioxide to diffuse across that membrane. And that's what makes things difficult for our patients. So all interstitial lung diseases have these things in common. But when we talk about there's over 200, how do they break down? So about 20% of patients are going to fall into the category of idiopathic pulmonary fibrosis. 20% are going to fall into connective tissue disease, interstitial lung diseases. 20% are going to be your chronic hypersensitivity pneumonitis. 20% are going to be this other entity we call sarcoidosis that we're still learning a lot about. 10% are going to be these other ILDs. I often feel like it's more than 10% because a lot of our patients, we just say, oh, I don't really know what this is yet. And maybe over the course of years, we'll uncover what it is. And then another 10% are things like pneumoconiosis. So I think of it when we're in clinic like putting a big puzzle together. And we have a bunch of pieces when we sit down with a patient, and we have to put them together to try to figure out what their diagnosis is. So what pieces are we going to use? Their history, their exam, their lab work, and their CT scan. And then there's another piece of the puzzle that sometimes comes into the picture, a biopsy. And we'll talk about that a little bit later too. So when we're sitting down to think about what kind of interstitial lung disease is this, we want to think about, do we know the cause or do we not know the cause? So let's talk about some of the causes of interstitial lung disease. So if we go down the path of the etiology is known, we have things like inorganic exposures can cause interstitial lung disease, asbestos exposure, silica. Organic exposures can also cause interstitial lung disease. I'm sure most of you have encountered a patient in your clinic that has or had a bird at home that has contributed to their interstitial lung disease. Also things like exposure to hay, molds. Smoking can cause interstitial lung diseases. Drugs that they've taken, like macrobid or nitrofurantoin, amiodarone, methotrexate. Methotrexate's a tricky one because we use that to treat interstitial lung disease sometimes. Chemotherapies that they've been on in the past. These can all be culprits as to why someone has interstitial lung disease. Connective tissue diseases. You may meet a patient who comes into clinic and they don't know they have a connective tissue disease. So not only are you going to give them a diagnosis of interstitial lung disease, but you also get to tell them they have a connective tissue disease and send them to the rheumatologist. Rheumatoid arthritis, polymyositis, dermatomyositis, scleroderma, Sjogren's are all common culprits. And then sometimes we don't know the cause, so that puts us into kind of our idiopathic interstitial lung diseases. And then there's rare forms like Lamb vasculitis, sarcoid. So how do we figure out where they land in that chart that we just looked at? Their history is so important. Taking the time to talk to your patient, asking them questions. Some patients will sit down and they'll tell you everything you need to know, but many of them, it's really important how you ask your questions. So asking them about things like, have you ever had mold damage in your house? And really kind of diving into that. I had a patient once and I said, any mold damage in your home? She said no. We kept going, conversation continued. About 15 minutes later, she said, well, when my house flooded from Superstorm Sandy, and I was like, oh, can we go back to that mold issue then? So sometimes they don't think about it right away. So you really need to kind of have a conversation with your patients. Asking about birds, if they've ever had birds, down feather bedding. Asking about their medications. Patients will very easily, often, not always, know what medications they're currently taking, but getting them to remember what medications they've taken in the past can sometimes be a challenge, so making sure you're asking good questions about that. Asking about their occupation and their prior occupations. I've also found that my patients who have served in the military don't always bring that up right away. When you talk about their jobs, they say, oh, well, now I do this, and I did this a couple years ago, but they don't volunteer their service time. So asking about that is important too. Smoking, and including vaping, because that's been kind of a bigger topic in recent years. I've had patients who have said, oh yeah, I quit smoking 30 years ago, but it turns out they're still vaping all day, every day. Asking about their family history. Susan just told us the importance of family history, right? There is a component of patients that many people in their family have interstitial lung disease. So knowing about that is important because that'll prompt you to dig a little further. And also asking about things in their family that may make you think they have something like short telomeres, early graying, liver disease, bone marrow problems. And then connective tissue disease, asking, like I said, they may come into your clinic without a diagnosis that you're also gonna give them. So asking them about skin or joint changes, muscle weakness, dry eyes, dry mouth, swallowing issues. All of these different questions are gonna help kind of steer you in your differential where you're going with your diagnosis. And then we're gonna look at their imaging. So we wanna get a high resolution CT scan. Many patients come to our clinic and they had a CAT scan, but it's not high resolution. So you wanna make sure you have a non-contrast CT that has thin section images. And there's a great position statement from the Pulmonary Fibrosis Foundation that will help you know what a high-resolution CT is versus what's not. One of the big things we're looking for is, do they have a UIP pattern or a non-UIP pattern? This is going to really help us narrow our differential, because a UIP pattern is the pattern that we see in idiopathic pulmonary fibrosis, right? The caveat being, it's important to remember that while all idiopathic pulmonary fibrosis ends up with a UIP pattern, not all UIP is idiopathic pulmonary fibrosis, but it does help you narrow your differential. So what are we talking about when we're looking for a UIP pattern? So both the Fleshner Society and ATS have put together kind of what the criteria for this pattern is. I'm going to show you some pictures on a couple slides from now about what some of these things look like. But when you're looking for a UIP pattern, you want to look and see, are the changes you're seeing on the CAT scan, are they subpleural and basilar predominant? So are they around the edges and on the bottoms mostly? And do you see honeycombing? I'll show you a picture of what that looks like in just a minute. But do you see kind of this, almost like a honeycomb, these small circular patterns that make a honeycomb? The Fleshner Society has kind of the same criteria. If you meet that criteria, you can sit in clinic and you can say, this is a UIP pattern, and then we can talk about, these are the diseases that often have this pattern, mainly idiopathic pulmonary fibrosis. Sometimes you have some of that criteria, but not all of that criteria, right? And so when you're missing that honeycombing, then we put you in this box of probable UIP. The next category would be indeterminate. That's the CAT scan you look at and you say, all right, well, maybe this is subpleural predominant. Maybe I see some reticulation. I don't really know what this is. You have interstitial lung disease, but it's indeterminate, right? Great category. And then there's the alternative category, or non-consistent. This is the CAT scan that you look at and you say, this is not idiopathic pulmonary fibrosis. This is clearly one of the other interstitial lung diseases. So there may be a lot of ground glass. I'll show you a picture of what that looks like. There may be a lot of nodules. There could be cysts. All of these things do not appear in a CAT scan consistent with a UIP pattern, right? So you can say this is an alternative diagnosis. It's not UIP. So this is just another kind of look at kind of what are we looking for. So with UIP, that's subpleural and basilar, honeycombing, reticulation. We're missing the honeycombing and probable. Indeterminate, maybe it's subpleural and basilar predominant. And the alternative just has inconsistent features. It's just something else. So here's a couple of pictures of some of the findings we see on CAT scan. So you see the honeycombing. Traction bronchiectasis is when the airways are kind of pulled apart by the scarring and inflammation, so the airway just looks bigger than it should on the CAT scan. Down the bottom, you have ground glass opacities. I don't know how well you can see it on these big slides, but CAT scan looks hazy, right? And then just the peripheral and basilar predominance of that last scan, kind of it's around the edges and down the bottom. So we look at their CAT scan. That helps steer us in some direction. The other thing that's important is their physical exam. So some of the things that you might find on their physical exam may point you to a diagnosis. You may see things like mechanics hands, Gotrin's papules. They can get a heliotropic rash. They can get a shawl sign, so a rash that looks like if you were wearing a shawl. A lot of these will point you to different connective tissue disease diagnoses, and we're going to hear some more about that later today. We also send a whole lot of labs. My patients always ask if I'm going to leave them with any blood. We're going to hear some more about the connective tissue disease workup later, but these are a lot of the labs that we look at. So we often look at things like the myositis panel. Some clinics will send a hypersensitivity panel, some will not. We send things like an SSA, an SSB. We look at the scleroderma labs, rheumatoid factor and CCP, looking for rheumatoid arthritis. We send an ANA and an ANCA. We send a CK and an aldolase. It varies by clinic, the labs that they'll send based on kind of the story the patient tells you and the exam findings that you have. In our clinic, we will often send most of these labs, even if we don't have something in their history or their exam that tells us they might have a connective tissue disease, because we've uncovered connective tissue diseases that were not apparent sending some of this lab work. And then we do a whole host of additional testing. So pulmonary function testing to look at how their lungs are functioning, right? I tell my patients, this is the biggest thing I'm concerned about. Their CT is important to tell me what they have, but I really want to know how their lungs are working. We often do a 6-minute walk test in clinic to look at their oxygenation and their conditioning. Some of our patients get an oxygen qualifying test so that we can qualify them for oxygen and meet those criteria we all hate to try to get patients oxygen. You'll hear a little bit more about that in the conference too, as oxygen is a hot topic. Sometimes we get an echocardiogram. Sometimes we get some additional testing to kind of help steer us. Swallow studies is another one that we sometimes look at. And then the question comes, do we biopsy you or do we not biopsy you, right? Biopsy is not a small feat, especially in patients that are coming to you with lung disease. Do you really want to sedate them and send them to the OR? So some of the things that we talk about are, can we make a confident diagnosis without a biopsy? So can we look at their CAT scan and listen to their story and look at their exam and say, you know what, I feel pretty confident that this is what you have. So if we can do that, do we really need to go get tissue to tell us what the diagnosis is? Is the patient at excessive risk for postoperative complications? If we're gonna make them worse or have a worse outcome because we sent them to the OR just to get an answer, it might not be the best thing to do. The biggest question that we ask in clinic is, will these biopsy results potentially alter the treatment plan? If I'm gonna treat you the same way, even if we find different things, do I really need to put an exact name to it? Some patients will tell you yes. And I can tell you that we've had some patients that have said, I know this isn't gonna change things, but it's really important to me that I have a specific name for my disease. So it's a conversation not only amongst the team, but a conversation with the patient when you're talking about biopsy, right? And then we also think about what kind of biopsy do we need? Because that changes the risk level. Do we need a surgical lung biopsy so we can get a big piece of tissue? Can we get by with just a bronchoscopy? Is a cryobiopsy gonna be enough? These are all questions we ask when we think about biopsying. And when do we have this conversation and think about biopsy? So we have a multidisciplinary discussion. We get together with pulmonologists, radiologists, the pathologist, sometimes the rheumatologist. We talk about all the things that we just talked about, the history, the exam, the CAT scan findings. And we say, as a group, can we figure out what this is? Or as a group, can we figure out what the next best steps are? And this conversation becomes really important as we're diagnosing patients. I know in my clinic, the patients get a lot of reassurance by the fact that we took their story to a group of people, and it's not just one person in the clinic that's trying to make their diagnosis. We can say, we talked with our whole group, and this is what everybody thinks you have, and this is what we think you should do. Or, we talked with our whole group, and you've stumped us all. We still don't know what you have, and this is how we're gonna kind of carry on from here. So our multidisciplinary discussion is a big part of the diagnostic workup. That's usually when we have some sort of answer for our patients, whether it's we still don't know what you have, or we know what you have. And that is the fast, quick overview of the diagnostic workup. And I promised you we were gonna hear more about the different things that we hear, that we see in clinic.
So thank you for having me. I'm glad to be here. I will be talking about pulmonary hypertension related to interstitial lung disease, which it just falls in my wheelhouse because I get to care for both of these separate patient populations in our clinic. And so it melts the two. These are my disclosures. Today we'll be covering, and I want you guys to be able to understand and recognize pulmonary hypertension and interstitial lung disease separately, but then be able to understand and recognize them when they do melt together and form their own diagnosis of PH-ILD. We'll go over the symptoms of both, the diagnostic criteria, the kind of screening and workup, as well as treatment and management potentials and complications of having both of these. So we just heard a great talk about interstitial lung disease. We know it comes with more than 200 different conditions and disorders that contribute to it. We heard about the symptoms that patients can have related to interstitial lung disease, the shortness of breath, the fatigue, dry cough, weight loss, decreased appetite, the whole gamut that really impacts the patients as a whole and their well-being. So we know these. We know the symptoms that these patients have. And that's what we're trying to cure, right? Improve their life there. So then pulmonary hypertension. Pulmonary hypertension is an umbrella term also. It is got 5 different categories, much different than the 200 with interstitial lung disease. So the 5 different categories that the umbrella term of pulmonary hypertension covers. Pulmonary hypertension is the development of elevated pulmonary arterial pressures. So the blood pressure inside the blood vessels of the lungs is higher than it should be. Nuts, bolts, simple pulmonary hypertension there. The different groups help us understand where that pressure starts. So group 1, pulmonary hypertension, is the idiopathic. These patients have pulmonary arterial hypertension, and the blood pressure inside the lungs originates inside those blood vessels itself. Group 2 pulmonary hypertension is related to left heart disease, valvular disease. The left side of the heart's not functioning like it should. The pressure changes originate there and kind of back up into the pulmonary arteries, contributing to that elevated blood pressure. Group 3 is what we're going to talk about, so fast forward to group 4. Group 4 is related to chronic thromboembolic pulmonary hypertension, or chronic blood clots inside the lungs. And then group 5 is our multifactorial, kind of catches all the others, one of which includes sarcoidosis, which makes things a little bit hairy when patients have sarcoid, interstitial lung disease, and then potentially PH. But we'll go back to group 3 pulmonary hypertension. This is related to lung disease. It can be interstitial lung disease, it can be emphysema, it can be hypoxia from untreated sleep apnea, or it can just be hypoxia related to their other underlying lung disease. To understand the blood flow through the body and where the pressure starts, a good analogy I use for our patients in Atlanta is traffic. And so in Atlanta, you've always got construction and traffic. And so I talk to the patients about the way blood flows through our body. It's kind of like an interstate system. I described 285 that circles Atlanta, going from the left side of the heart out to the body, from the body to the right side of the heart, right side of the heart to the lungs, and then the lungs to the left side of the heart. And so where's the construction going on? Where are the lanes narrowing? Where are the cars backing up? Kind of thing. And so that helps them kind of conceptualize what we're talking about and understand it better. Oops, fast forwarded. Is there a back? There may not be a back. Cool. Okay. So, pulmonary hypertension is a change in the cells that line the blood vessel walls. And so you can get the endothelium that lines the blood vessel walls that get injured and get inflamed, and then they can repair inappropriately, so the endothelial lining can thicken and get stiff. And then the smooth muscle that lines the blood vessels there can also hypertrophy, get larger and swollen, narrowing those blood vessel walls. And all of this, when you get narrowing of those blood vessel walls, of course, increases the pressure within those blood vessels. And then when those blood vessels narrow, it causes a pressure change behind it, causing the right side of the heart to have to work harder to pump the same amount of blood through those smaller blood vessels. And then that's what starts to impact the right side of the heart. And so when I talk to our patients about pulmonary hypertension, I circle back and tell them what we're very fearful of, what we need to watch out for, and what really we want to prevent, and that is the impact on the right side of the heart. The right side of the heart getting stretched out, swollen, the muscle of the heart not being able to function as it should, all leading to right heart failure. And so I always like to tell our patients where we're starting, what we're looking at, what we're trying to prevent, and then what the symptoms and things are that we look for that tell us whether we're in the right direction or wrong. So preventing that right heart failure is kind of our goal in helping manage the pulmonary hypertension side of things. So pulmonary hypertension symptoms, you've got the progressive shortness of breath, dizziness, fatigue, chest pressure, heart palpitations. Patients feel like their heart is just beating out of their chest, especially with exertion, and then decreased appetite. So a lot of this looks the same as what our patients with interstitial lung disease have already been experiencing. So how pulmonary hypertension relates to interstitial lung disease is a little bit different. So we know about pulmonary hypertension, pulmonary arterial hypertension, and the group 1, but what does that really look like in our patient population with group 3 pulmonary hypertension? And current state, that's not completely well understood. There's a lot of thoughts that we have, like the fibrosis of the lung parenchyma, the change in the lung tissue itself, destroying the alveoli in our lungs, causing hypoxia, causing changes in the blood vessels that abut those alveoli for the diffusion of the oxygen-carbon dioxide exchange, and narrowing those blood vessels, those capillaries that really come up to those alveoli, increasing the pressure behind it when you have less of those capillaries for the blood flow. Hypoxia itself can really cause vasoconstriction and narrowing of those blood vessels. So when you get less alveoli because of the interstitial lung disease process, the scarring, that contributes to the hypoxia. And these patients may be fine at rest, like we know, but when they get up and exert themselves, they can get pretty hypoxic. But also at night, these patients, our patients with interstitial lung disease without sleep apnea, can get pretty hypoxic when they sleep too. So that could play a role in the vasoconstriction and development of pulmonary hypertension in these patients. And then the already known faulty repair process that these patients have on the cellular level. So when injury occurs to those blood vessels and the cells that line the blood vessel walls, how does it repair? Can it repair normal, or does it get stiff and scarred and thicker than it should be? The relationship between pulmonary hypertension and interstitial lung disease is not a one-in-one also. We can't say, oh, you have a little bit of pulmonary fibrosis, so you have a little bit of pulmonary hypertension. I think our bodies are a lot more complex than that. So you can't say the patient doesn't have pulmonary hypertension because their CT scan doesn't really show a lot of pulmonary fibrosis. So we don't yet understand what that looks like either. It's important for us as healthcare professionals to recognize this and make sure that we're staying attuned to patients' symptoms and digging further if patients come in and they have either a lot of fibrosis or a little, but are still having worsening shortness of breath and chest pressure and things like that. So the prevalence is not completely understood here either. There have been a lot of studies looking at this, but part of these studies have used inconsistent data. Some of them have not had right heart caths incorporated, and so we can't say right now exactly the prevalence of PH related to ILD and then be able to tease it out into which ILD. Is it connective tissue disease? Is it idiopathic pulmonary fibrosis? We don't yet know. We need more studies, I think, that will help characterize the ILD and the PH so that we may be able to eventually pinpoint who is more at risk or who is less at risk. All right. We do know, though, that idiopathic pulmonary fibrosis patients have had pulmonary hypertension at time of diagnosis and at time of autopsy. And so how impactful their pH was to their life and their symptoms, we don't yet know, but we do know that it's there. And so we need, as healthcare providers, to be vigilant and aware and dig further into that, because if we can identify that and help them live a more meaningful life with less symptoms, then that should be our goal. So PH-ILD is the great pretender. Our patients and their journey to their diagnosis of ILD has been long. They've seen multiple providers and been told, it's pneumonia, bronchitis, all that before they even get their interstitial lung disease diagnosis. And then they see us as care centers and experts, and symptoms persist. We need to make sure we're not missing anything else that could be contributing. So asking about their symptoms, their shortness of breath, understanding what their trajectory has been, and when changes occur, and making sure that we're unfolding all the layers and understanding completely, what's impacting them the most. We also know that patients with PH and ILD have worse outcomes. Their morbidity and their mortality is worse. And so we need to improve that. We need to make them feel better and have a better life with less symptoms. And so this kind of goes over the PH-ILD symptoms. They're the same as ILD. They're the same as PH. And so it's kind of hard when you get a patient come into clinic, they've been doing well, and then all of a sudden their symptoms are progressively getting worse. That needs to be a red flag. We really need to have a high suspicion with these patients. And so with that, we need a low threshold to dig deeper and understand more what's going on with our patients. So getting the screening test, we've already done it. We've done the pulmonary function test. We've done the walk. We've done the CT scans. Let's make sure that we don't forget about the right side of the heart and what can be impacted by that. So when we screen these patients, things specifically to look at are the diffusion capacity in your pulmonary function testing. If your flow volumes, if your forced vital capacity hasn't really changed, but the diffusion capacity has, then that needs to be a red flag. And then digging deeper and getting a BNP or an NT-proBNP. This is a lab test that kind of tells us how happy or not the right side of the heart is. And then getting the echocardiogram, looking to see what the function and size of that right ventricle is. Echoes are really good screening tools. They're not diagnostic for pulmonary hypertension. And in our patients with interstitial lung disease, they can be more difficult because the images to get the echo have to go through the lung tissue. And we already know that lung tissue is scarred, and so that can impact the view that we get. But it is a good screening tool. We just have to understand what we're looking at when we see those echoes. Other tests we can get are CPETs, cardiopulmonary exercise testing, help identify which is more impactful. Is it the pulmonary process or the cardiac process or the deconditioning? Should we send the patient back to pulmonary rehab? But making sure that we keep digging, keep diving, and not just say you're kind of stable. This is the slow trajectory. So the diagnostic criteria for pulmonary hypertension is the right heart catheterization. It's a relatively simple, low risk, is invasive outpatient procedure by a cardiologist or pulmonologist, where they go in and actually measure the pressures within the right side of the heart and in the pulmonary arteries themselves. I don't think that we should be afraid to send our patients for this, especially when we talk to our patients about transplant. Patients that we send for transplant evaluations will have to get a right heart catheterization anyhow. And so being afraid to get this and send them to the lab will only potentially delay their diagnosis. And then if we're sending them to transplant anyhow, they may uncover it then when it's progressed further, and may impact their transplant potential too. So pulmonary hypertension, what the diagnosis and the pressures that have been used in the studies that we have had used a mean pulmonary artery pressure of greater than 25. Current guidelines for the diagnosis of pulmonary hypertension now is greater than 20. So that goes back to our diagnosis and prevalence of PH-ILD. When the definition of it has changed, we got to circle back and align the new definition with the results the patients have had before. But a mean pulmonary artery pressure greater than 20 is what is current state for pulmonary hypertension, with a wedge pressure less than 15 and a pulmonary vascular resistance greater than 3. And so there are different classes and pressures to meet this pulmonary hypertension. This goes back to my construction and traffic jam here. Is the pulmonary pressures elevated prior to the capillaries in the lungs, post the capillaries in the lungs, or within the capillaries of the lungs? And so getting that right heart catheterization helps us identify where the pressures start. And so once we've gotten the workup, we've gotten the diagnosis, there are opportunities to improve our patients' symptoms related to this. There has been FDA approval of inhaled treprostinil. Treprostinil is a prostanoid therapy. It causes vasodilation, dilating the blood vessels in the lungs. It has an anti-proliferative effect, changing kind of the vascular smooth muscle, the cells that line those blood vessel walls, helping them kind of regenerate in a healthier way. And inhibits platelet aggregation, so the backup of the cars and the traffic, helping blood flow a little bit more easily. And so inhaled treprostinil has been approved by the FDA to treat pulmonary hypertension related to interstitial lung disease. In the BREEZE trial and INCREASE, it has shown that patients feel better. Their 6-minute walk data is improved, and so they're able to do more and be less symptomatic with that. And so that's an opportunity to offer patients something that will impact their daily lives. There have been other studies on other medications to treat pulmonary hypertension related to interstitial lung disease using endothelial receptor agonist and PDE5 inhibitors, medications that we use for pulmonary arterial hypertension. But that data has come back showing lack of efficacy and potential harm in some of those. So those are not recommended at this time. And then we also need to understand that we're treating pulmonary hypertension related to interstitial lung disease. So let's make sure that we are treating that interstitial lung disease, that patients with connective tissue disease, ILD, are on the right immunotherapy, that we've offered antifibrotics, and that we're not losing sight of the other things that impact their life, making sure that they're getting the oxygen that they need, and they're not getting hypoxic trying to get out and do things. Manage their other comorbidities. Unfortunately, our bodies are dynamic, and we don't get just one diagnosis, but we need to manage everything else. Make sure we've got them in pulmonary rehab. Get nutritional support. Make sure they're getting their protein and understanding what they can and can't eat. Making sure they're taking diuretics, because when the heart doesn't function appropriately, it's not processing the blood and fluid through appropriately, and these patients with right-sided impairment can get swelling and fluid retention and weight gain. And then all the other things, smoking cessation, making sure they're getting their vaccines. All of those things are really important. Let's not lose sight of the whole person that we're looking at here. And so management strategies also, I'm a big believer in therapy, making sure patients have somebody they can talk to, because they've been diagnosed with interstitial lung disease, but now they have an additional diagnosis that's pretty heavy that comes with that. So making sure that our patients have a way to talk to somebody and process this and have social support and have their person kind of involved. And then talk about transplant evaluation again. I tell my patients that transplant's on the table until it's not, but it's not something you can pull the trigger on today for tomorrow. It's a workup, it's a process, so it's something we always keep in our toolbox and make sure that if we need to pull it out, everything we've been working towards is aligned with that, and there's not going to be hiccups or surprises when it is the right time for the right patient to get that. And then palliative care. I know in Atlanta it feels like it's just starting to get there. We've got more access to palliative care providers, and patients can get to them easier, but having palliative care involved to help look at the patient and see them from a different view is really important. And so getting to the care team part of this, I think it's really unique that we can come together from different disciplines and see the patients and bring their stories from each of our sides and make sure that we're taking care. I think this is the family nurse practitioner here and me, the whole person here. And so making sure that we've got our care team together with the patient, reviewing all of this when new data comes about, so that we're looking at them as a whole. And so the consequences of PH-ILD are pretty great. So these patients have more symptom burden, they have worse outcomes, higher mortality, and so if we can catch this early and help improve the time that they've got here and potentially halt the disease progression, then that's what we should be doing. We shouldn't lose sight and forget that there are other things that can go on with these patients with interstitial lung disease. I did have a case study. I've got a few minutes left, and I'll run through this real quick. I tried to be pretty quick. But we had a patient, met her several years ago, 71-year-old female. Her primary care had referred her to us. She had had several bouts of pneumonia, had persistent coughing, and had just a history of acid reflux. She smoked, but it had been decades. And so she was sent to us. Her initial exam, cardiac-wise, was fine. Her lungs, she did have bibasilar rales. I could hear it in the bases. She didn't really have wheezing, didn't have a diagnosis of asthma or anything like that. I think that if this primary care hadn't referred her to us, maybe she would have eventually. No edema, so really her symptoms were cough and shortness of breath with this history of recurrent pneumonia. So we did the whole ILD workup. We got the labs. We got the CT scan. She did come back with positive ANA. So we did make the diagnosis of connective tissue disease at the same time as the interstitial lung disease. We got the high-res CT that was a UIP pattern. Her forced vital capacity, her forced expiratory volume, her lung function studies in the realm here were pretty preserved. Her diffusion was a little bit low there. Her walk, she did desat with walking, and then her heart rate jumped way high while she was doing it, but recovered pretty quickly at the end. And her echo was normal. Her left side of her heart was normal, right side of the heart was normal. Her right ventricular systolic pressure, which is kind of that guesstimate of what the pressure is within the pulmonary blood flow, was near normal at that time too. So we made the diagnosis of connective tissue disease, ILD, referred her to a rheumatologist. She started on Cellcept. Made sure we talked about that acid reflux, got her on a PPI, talked about, elevating the head of the bed, watching what you're eating, all of that kind of stuff. Got her in pulmonary rehab. She'd been doing pretty well. We continued to follow her, but fast forward, 5 years later, she comes back. Current state, she's done pulmonary rehab. She had stayed pretty active, but was noticing it's harder to keep up with grandkids, feeling more fatigued than usual, and having a harder time recovering after exertion. Her dry cough is still there, but she's kind of, that's par for the course, is what she says. She's remained on her Cellcept. That hasn't changed. Her rheumatologist was happy with their therapy there. She still, of course, has the bibasilar rales. Cardiac exam was regular rhythm. She did have some edema in her legs at this time. So we repeated the CT scan. It's progressed a bit more. She now has some honeycombing and some bronchiectasis. Her pulmonary function tests have worsened also, specifically the DLCO, the diffusion number here is 35%. Kind of the 40% is kind of the number that I would start looking at and think a little bit harder. So she was 35%. Her walk was almost 100 meters less than what it was at diagnosis of her interstitial lung disease, even though she's done pulmonary rehab and all of that and stayed active. And we repeated the echo. The left side of the heart still looks good, functioning normally. But the right side of the heart, that right ventricular systolic pressure has increased over time at 51. And the TAPSE here describes the function and the squeeze of that right ventricle and how well it's moving and pumping blood through the blood vessels of the lungs. So high suspicion that something else is going on because her repeat pulmonary function and the forced vital capacity wasn't significantly different, but the diffusion was, the echo was, the symptoms she was having were progressive. And so we got the right heart cath. The important numbers here are the mean pulmonary pressure is elevated at 30. Her wedge is normal, which gives us an idea of what's going on beyond the lungs. And then her pulmonary vascular resistance, that PVR, is significantly elevated. The things I didn't include here would be cardiac output and index, and those were preserved and normal too. So we did get her enrolled and started on the inhaled treprostinil through the nebulizer device, and so she has she's been doing well on this. Our patients with interstitial lung disease have this chronic dry cough, and that can be one of the main adverse effects with this inhaled Tyvaso. And so I always use caution and talk to the patients about how we can mitigate that and what to look for. She's continued on her CellSapt, continued on acid reflux, nutrition discussion about protein and calories, as well as limiting sodium and monitoring how much fluid she's getting, and starting to monitor her weight every day, especially with the signs of the leg edema. And then we started her on a diuretic as needed. She's one of the patients that I feel pretty confident that she's pretty attuned, so she can help decide whether she needs it or not. So really what I want you guys to get out of all of this is let's be attuned. Let's make sure that we're recognizing when patients' symptoms don't fit what we've already diagnosed them with, and when something else could be lurking in the background. Let's not delay looking into it in a watch and wait kind of fashion. If we see something that's concerning, dig deeper. Let's not make the patients wait even longer for another diagnosis. And understanding that the symptoms are the same, and so they can pretend either way. And then there are things that we can offer to help these patients feel better, get back to life, and help them manage it along the way. So thank you. That's it.
So this can be an hour-long presentation, but I really only have 25 minutes. So, autoimmune ILD and the patient journey. So originally it was supposed to be what we're testing for, but really it's a combination of both, what you're testing for and what you're looking for. So I have no disclosures. So the objectives today, we are going to obviously discuss autoimmune ILD, what extrapulmonary manifestations that you're looking for, and the types of testing that's done, and how are patients classified based on their diagnosis, and hopefully, if we have time, treatment as well. So as stated before, we know that ILD consists of over 200 different causes, and that the diagnosis can be challenging. As seen before, again, this is the different types of ILD. I go into extensive detail, but I won't. So, autoimmune ILD consists of rheumatoid arthritis, systemic lupus erythematosus or SLE, mixed connective tissue disease, and undifferentiated connective tissue disease, scleroderma, Sjogren's, and dermato and polymyositis. So generally, well, this slide, it's in relation to our clinic here at Johns Hopkins, but about 1/3 of our patients, whether known or unknown, actually end up being diagnosed with some form of autoimmune disease. So assessment. When you, as stated before, when you see your patient, you really want to get an extensive and thorough history. You want to get to know them, know their hobbies, get a good look at them. When they present in clinic, if possible, have them actually take off their shirt, take off their socks, and ask them about their skin changes, and just kind of, I would say, especially now with COVID, it's been a long time since patients have actually gotten a thorough head-to-toe examination in which their joints are assessed and that we're asking questions outside of pulmonary. So extrapulmonary signs and symptoms consist of alopecia, Grotrin's papules, mechanics hands, Raynaud's, sclerodactyly, joint inflammation, calcium deposits, difficulty swallowing, joint pain, also and pleurisy. Sometimes patients will describe that as like a nagging pain, like when they take a deep breath, or they feel like when they do take a deep breath, they have to stop at a certain point. So in regards to rheumatoid arthritis, generally speaking in clinic, I find that it's mainly women that present with RA, but actually it's found more commonly in men, and it's actually more severe in men. The risk factors include being older in age, male, history of smoking, and the things that you want to look out for are malignancy, repeat infections, PEs, DVTs, and their scans generally present in a UIP pattern, and if so, it's associated with poor quality of life, but also NSIP is associated with rheumatoid arthritis. So this is X-ray. So if someone presents into your clinic with their hands like looking like this, or if they have a history of rheumatoid arthritis, determine whether or not that they have a rheumatologist that they're being followed by. So this scan, what it shows is inflammation of the MCPs and the PIPs and erosions of the cartilage in their joints. Inflammatory myositis. So this is my love right here. It consists of a generalized, I guess, cluster, right? There's another phrase that goes after that, but a cluster of symptoms that occur in a patient, and it's systemic. So that consists of various rashes. We have, as I stated, mechanics hands, digestive issues. I'm going to go into it more on the next slide. So with dermatomyositis and sometimes in polymyositis, we have the skin manifestations of poikiloderma, which consists of like a well, initially it starts off as a red rash or inflammation on a patient's chest, also known as Schall's sign. But if it's not picked up early on, it actually can become an area of hyper and hypopigmentation. Also, on the bottom bottom left, we have an older woman with a facial rash. So these rashes actually you can see it in dermatomyositis, in lupus, you can see it in rosacea. So, it's just a matter of when and where you see it. So ask questions like, does it present with sun? Is this something that only happens with a viral illness? On the scalp, we have the same poikiloderma that's on the chest. It can actually happen on the scalp as well. And then we have Grotrin's papules on the bottom right, and then up on the top left, facing you guys, we have periungual thickening and telekinesis. So continued. Primarily being that myositis is seen, I find in our Baltimore area clinic in mainly younger African-American men and women, when you see these rashes, on fairer skin types, it can present as red, erythematous, itchy, or depending on the cause. But you actually want to look at them and, it's not eyeliner. Like ask them, is this eyeshadow? Is this what you look like on a daily basis? Does this change with skin exposure? Same thing for like the knees and the elbows. When you're assessing these patients, ask them, are their knees normally this discolored? On their back, is this, acne or back knee, or is this something that has erupted and comes and goes? Also, you want to consider, do you see this in any family members as well? Because you can have a family that has, my aunt has lupus and someone else has a diagnosis of scleroderma or myositis, or sometimes no one's ever diagnosed it, but they too have the same symptoms. So as stated before, sometimes these rashes, they all look the same. So that is actually a malar rash for a young woman who has SLE. B is another young woman who has dermatomyositis. C, we would think is an autoimmune disease, but in actuality, it's rosacea. Same thing on the bottom. I have A, which is Gauthrin's papules, and also mechanic's hands, it appears like on the dorsal side. And then B is actually cutaneous lupus. C is actually dermatomyositis. And then D is a lupus rash as well. So again with lupus, you want to, this is an extensive list as to what body parts that it does affect, but we also want to make note that it is restrictive physiology and that these patients, they can have something called shrinking lung, an elevation of their diaphragm. So there is restriction when they're taking a deep breath. Also, these patients, they also present with a lot of pleurisy. So unfortunately, it's not something that we can, it's not a quick fix. I have a patient in clinic how she was told that she had costochondritis. No matter what we did, it just never went away. She took NSAID, she took Tylenol, she tried unconventional meds, and nothing was working. But in clinic, we tried pain ease, it's like an Emla cream, like a spray. Sprayed it on one good time, and she was like, I haven't had relief in months, and this works better than any opioid. So sometimes it's just and exercise as well. So sometimes it's just a matter of listening to the patient and not ruling out their symptoms, because no two patients are alike. Also with this patient population, you want to consider their risk for pulmonary embolism, especially if they had, with antiphospholipid syndrome. So with systemic sclerosis, again, another systemic disease that affects the lung, musculoskeletal. These patients also have Raynaud's and skin manifestations. What I find with these patients is that sometimes it's not easy to diagnose them. You want to ask your patient when you're, do they notice any skin thickening? If you're, touching their skin and you're like, you know what, or if you're drawing labs and it's just hard to get through, determine whether or not, hey, when you look in the mirror, not to say they got a facelift or something, but do you look the same as you did 6 years ago? Or do you notice that your hands are getting thicker, or it's difficult to squint or make a smile? So definitely ask them, about their skin changes. Also, previous slide, just to touch base on scleroderma, being that steroids is one of the main treatments in patients with autoimmune disease, they are at risk for renal crisis, so you just want to be mindful of how much steroids to give them. So in regards to Sjogren's, it's an autoimmune disease in which the immune system attacks the patient's own mucus-producing glands, such as those of saliva and tears. This can also affect their throat. It can cause xerotrachea, but these patients are also at risk for malignancy. So in regards to testing for autoimmune disease, initially these patients would present, and unfortunately I'm sure as many of you know, when they come into clinic, they've consulted Dr. Google and they think that they all have pulmonary fibrosis and that they all have 3 to 5 years to live. But the purpose as to why they come to these care center networks and to come into your practice is to figure out really what's the cause of their disease. They already know that there's over 200 causes. They're not sure what it is, and it's it's our job to alleviate that panic that they and their loved ones have. So their workup is going to be pretty extensive. As stated before, there are a number of tests that are done. So your extrapulmonary assessment actually makes an impact as to what your focus would be. So laboratory testing, you want to get your basic labs like a CMP, CBC, BNP. You want to get, depending on the history that you ascertain from the patient, if there's a genetic makeup that needs to be done. Also, talk about their cardiac history, right? If you notice some things that may lead you to an autoimmune route, you want to throw in that echocardiogram if they've never had one, so that way you get like baseline, so that way you'll get like a baseline echo. And especially with our patients with autoimmune disease, you actually want to get an echocardiogram on average about once a year, or if their symptoms change. If you notice any edema, you actually want to throw in a pro-BNP just to assess, whether or not there's some heart failure or some, component of pH. So as the slide shows, these are the labs that I tend to focus on when patients come into our clinic. But also our PFF, they have a great resource guide I actually like to give to new fellows when they come into clinic, or anyone who has questions about ILD. Like, these are like a quick and dirty resource that you can have in regards to labs that you can draw. The ones that are highlighted in red are generally towards autoimmune disease. In our clinic, we send an OMRF panel. It's from the Oklahoma Medical Research Foundation. It takes about 3 months to return, but it actually gives us an extensive panel as to the autoimmune diseases that are the antibodies that are commonly found with autoimmune disease. We do have like a myositis panel that comes back within 7 to 14 days that we do in the meantime, but this actually gives us a really good assessment of our patients. So high resolution CT scan clues that I like to see in autoimmune disease. So what I like, our CT scans, the patterns are not the diagnoses. They're patterns of injury. So what we see in CTs are generally multi-compartment involvement, sometimes a dilated esophagus, especially in scleroderma, pericardial thickening, and the patterns that we generally see are NSIP, UIP, LIP, OP. Our CT scans, especially in our connective tissue disease patients, we see a straight edge sign. The straight edge sign has been associated with NSIP. Actually, this one is from a 37-year-old woman who has systemic sclerosis. Systemic sclerosis. Also exuberant honeycombing sign. You can see this in, again, patients with CTD ILD. And then also the anterior sign. Once you see, it's not to say this is the all that ends all, but it does lead you down that pathway. So if you have a patient that comes in with the initial diagnosis of pulmonary fibrosis, and these are the scans that you see during your MDT, if their workup hasn't been completed or those labs haven't been thrown in, definitely add those in. Also of note, sometimes these actually, the pulmonary manifestations can present prior to the physical manifestations of their autoimmune disease. So it's not necessarily to say that they don't have an autoimmune disease, except that when they presented, either in your clinic or during admission, that they actually had, whether it's a viral illness or something that precipitated this event, that they actually do have an autoimmune disease. So just a generalized slide on treatment. It does consist of immunosuppression. Those are mycophenolate, azathioprine, tacrolimus, Cytoxan, depending on your facility, Rituxan, and steroids. I didn't add on methotrexate because generally I like to leave that to the rheumatologist. And I know, as some of you know, with Rituxan, if I know in my clinic it is very difficult to get it approved without having the patient seen by a rheumatologist. And then also we add on IVIG, and we do recommend pulmonary rehab, have them see a nutritionist, and just kind of help their overall well-being, because this isn't, I try to tell patients, you know, this is day one in which we know what it is that you have. I do not expect you to be where you are today a year from now. And if everything works out the way it's supposed to be, hopefully you feel better if we can get this inflammation under control, and if we can, you know, treat you accordingly. And sometimes it's not a one size fits all. So what would generally work with one patient, and if your go-to is mycophenolate or azathioprine, sometimes these patients need multiple therapies in order to get that, I guess, not relief, but like in order for them to get that stabilization, as you would say. So resources, I'm obviously clearly PFF, American College of Rheumatology, OMRF, if you guys are interested, you can actually pick and choose how you get your labs done, National Scleroderma Foundation, and the Myositis Association. And these are my references. Thank you if you have any questions.
It's an honor and a privilege to be here, so thank you for having me. We're going to talk about pulmonary rehab and a little bit about oxygen therapy, and then Nicole is going to talk about different oxygen devices during her talk. I don't know how to advance the slides. Hey, it's magic. All right, so just a little nervous, so bear with me for a few minutes. Anyway, I actually have nothing to disclose, as you can see here. I do quite a few talks, and I teach at the College of Science at Rush University on pulmonary function and trying to educate people on their disease process and making sure that others continue the field and help to promote patients' advocacy. So the objectives of this, we're going to talk about the key components of a pulmonary rehab program. The idea behind it is to promote behavior changes and self-management of the underlying lung conditions through education and training to help people be empowered to do more with their own lives. So you're going to discover what pulmonary rehab can do for you and for your patients, how they would find an accredited program. There's a lot of programs out there. You want to make sure that patients get into the right program where they're getting the right help, they're monitored closely, they have everything they need, and they don't wind up with a huge bill at the end of it. Do patients on oxygen benefit from pulmonary rehab? Absolutely they do. And I'd like to emphasize the importance of wearing oxygen when they exercise. There's a stigma associated with it that when patients go to exercise or they go out in public and they're wearing their oxygen, they don't want anyone to know they have oxygen. So they'll tend to leave it at home, leave it in the car, wear themselves out, and then not be able to recuperate after they're done. So pulmonary rehab is available for a huge variety of chronic lung conditions. They've opened it up to more and more over time, and even post-COVID-19 lung disease has hit the charts. So if you know anyone that is struggling with lung disease, please refer them to a program, because it actually helps teach them ways to deal with it, to better live their life, and to be able to carry on their daily activities in a normal function and to recuperate faster. So what can you expect when you're going to pulmonary rehab or you're sending someone to pulmonary rehab? It's a specialized program for individuals with chronic lung disease. There's 5 essential components to a rehab program. There's the initial patient assessment, there's patient exercise and training, there's a long process of patient education that covers a lot of different areas of education for them. There is a patient reassessment, and there's what we call a maintenance program once they're done. So again, what can you expect? The exercise sessions. What if you can't exercise right now or your patient says, I can't do anything? They start them out in a chair and they do soft exercises to slowly work up endurance, work up a little bit of muscle tone, and help them to do things. Program times vary based on their need. Programs can be anywhere from 4 weeks to 16 weeks based on the patient's necessity, based on their need for what they need to work on, what their goals are, what they'd like to do. Their progress is monitored, and the exercise is increased as they're able to tolerate it. Forgive me. It's very important for the patients and for the caregivers to emphasize that they need to attend every single session. They learn something each time, and They keep track of what they're doing and what their progress is. So the first thing is the assessment. So they assess the functional impairment. What is wrong with the patient? Do they need a walker? Do they need special things when they're exercising? Are they able to walk on a treadmill? Do they need to walk on flat ground? Do they need to start their exercise in a chair? They exercise what their capacity currently is, and they document everything. And then they work on moving forward. So they provide information to the patients on the importance of performing the exercise, what it does for their body, what it does for their mental capacity, how it helps their overall activities of daily living. And then we like to promote them to continue to exercise once they've completed the program. They make huge headways, and then people sometimes just stop because they're done exercising. You want to continue to keep that exercise up, keep that muscle tone, and keep that independence for the patient. So we request a repeat assessment post-exercise so they can actually see their activity from the beginning to the end. Generally, you need a 6-minute walk, and that's used to evaluate their functional capacity. How far they can go when they're doing that 6-minute walk, what their oxygen level does, what their heart rate does, and what their blood pressure does, indicates how well they're able to function now. So it takes a look at how you're doing right now, and then they ask the patient what goals they want to achieve. What would their end outcome be? Some patients just want to be able to go to the mall with their grandchildren. Some people want to be able to climb the stairs in their home. Some people want to be able to take a shower without being out of breath. So they come up with all the different ways for people to do that. They teach you breathing techniques so that when you overdo it, you can recuperate faster, get back to normal better. It does allow you to increase your ability to exercise. So you start out maybe only being able to walk from table to table, and then they're able to walk the whole mall when they're done. So it also improves their stamina, and it improves their distance, and it improves their outlook on their life. So the education, it's tailored to the learning needs and the goals of each particular patient. So it's not one size fits all. You don't go in and they check a bunch of boxes and off you go. They tailor it to what the patient wants, what they're doing, what they need, and what they'd like to have happen at the end. So the techniques and the resources that improve the shortness of breath, they teach them breathing techniques. They teach them steps that they can take when they're taking a shower. You know, by the time you get undressed, get in the shower, get washed, get dried off, they're completely spent for the day. So they teach them ways to make it last a little longer, so that they're not as tired when they're done. They break it up into sessions and teach them breathing techniques. It helps the patients to become more active participants in their own health care. So why go to pulmonary rehab? Helps you to regain your strength and increase your stamina. It helps the patients to stay independent, which is very important. When somebody's on oxygen and has a chronic illness, they begin to withdraw, isolate, not want to go out, not want to do things. It's very important to help them stay independent, let them know they can remain independent, increase their stamina, increase their activity, increase their abilities if they want to bake or cook or do something. It lets them know that it's okay. They learn skills that improve their quality of life, which includes improving the quality of life of everyone around them. All right. So they develop problem-solving skills, right? One of the problem-solving skills are the barriers to success. A lot of the barriers to success is depression and anxiety. They're very real. And patients who have severe pulmonary fibrosis are afraid to be left alone. It's very natural, very normal. So they teach them ways to cope with it, and pulmonary rehab provides counseling along with it. So they provide you with the essential tools to better manage your own lung disease and to help these people to have happier, healthy families. So you decide you want to go to pulmonary rehab, what are you going to do? You're going to discuss this with the physician. First of all, they need to see if they qualify. So if they qualify, the physician usually does a 6-minute walk or a pulmonary function test, which is a PFT, and then they'll forward all the information. You complete the screening. You schedule your sessions with the place that you're going to be doing it at. There's plenty of staff there to watch the patients and the family. You know, generally they'll let a family member go with, but they can't participate in the exercise, but they'll give them updates. They'll keep a very close eye on the patient, make sure that they're safe while they're exercising. It's usually run by nursing and respiratory therapists. There is cardiovascular and pulmonary rehab facilities that are kind of joint. So if somebody has a heart attack, recovering from heart attack, they're watching them, they're doing it in the same place. So these patients meet other patients and create a network. They end up having other people who have the same illness in common and things to talk about. So they create these bonds and these friendships, which is very healthy for them. Vitals are monitored routinely, and it's usually, we want you to be at an accredited facility. So there's a couple of websites up there just so that people can know, and there's a whole list of them in every area of the country. There's a lot of facilities available. So the physician or the care team is the one that refers the patient to it and lets them decide where they want to go. They can pick someplace close to home, and then they'll fax over all the information. Most of these programs are covered by insurance and by Medicare. So my thing to the patient is don't be afraid of overdoing it. When they're in pulmonary rehab, they want to push it when they're being supervised, not push it when they're home alone, climbing the stairs, doing things that they're not sure if it's good or not. So the care team monitors them closely to make them more comfortable when they go. So the first thing the patient has to do is decide if they want to go to pulmonary rehab, right? So the first thing they have to do is discuss it with the doctor, or the care team needs to approach the patient with it. Then they find a list of approved programs, have the doctor fax over the paperwork that's required for that particular center, have the patient schedule the appointment for the initial screening. Sometimes these initial screenings can take up to 4 to 6 weeks to get into before they even get set on their schedule for going to pulmonary rehab. So the rehab coordinator can tell the patient what the cost is, if they're covered by their insurance, if they have to do a copay, however much it's going to cost. And most of these programs are covered by insurance and by Medicare, up to 16 weeks. So have them get started and breathe easier. So in summary, you just want them to kind of talk to their doctor and decide if pulmonary rehab is right for them. Some patients don't want to go, but it's a wonderful benefit, and it really does improve the quality of life. Complete any necessary testing that's required for the facility. Like I said, generally a 6-minute walk test. And if they're on oxygen and need oxygen, the 6-minute walk test will tell them how much oxygen they need to exercise. Write down any questions that you might have before you go to the pulmonary rehab, because when you get there and they're asking you information, they're going to forget. So get enrolled in a pulmonary rehab. Make sure you find an accredited program near you. Schedule that initial assessment. And when you schedule that assessment, they're going to set up a schedule. Sometimes it's 2 times a week, sometimes it's 3 times a week, based on what the patient needs and their progress. If you can't make it for all of those sessions, let them know up front, and they will work around it with you. They're very flexible and very helpful for you. They want to see the patient succeed. Make sure that you complete the program. If your program is 12 weeks, try to get in all 12 weeks, because it's to the patient's benefit. And for caregivers, emphasize to your patient what a difference this can make in their lives. Have the patient continue to exercise once the program has completed. Perform a reassessment after the program is complete, and then they can see on paper what they were doing before and how much more they're doing now. It really is amazing to see the journey some of these patients go on. And then they can evaluate the difference, but they get to enjoy their independence more. And then they can set higher goals, and they know when to stop, what training they can do, and how far to push it, and when they need to relax and regenerate. So exercise and portable oxygen. This is something that I see all the time because I am a respiratory therapist. Patients will stop wearing their oxygen. As I said, they're going to go exercise, but it's too cumbersome to carry. They don't want to bring it with. They don't want anybody to know they have it, and they'll push it. They'll wipe themselves out while they're exercising, and then what happens is they don't have the ability to recuperate quickly. They've used all of that energy. So when the heart starts pumping really fast and there's not enough oxygen, it's going to send it to the vital organs. It's not going to send it to the muscles and the tissues. So the legs feel fatigued. Patients start to walk and they say their legs feel like they weigh 1,000 pounds, so they stop. It takes a lot longer for their bodies to recover if they're moving around and exercising without their oxygen. And a lot of people, I know people that hide it in the closet when they go to work, and they stick in there and do a few breaths and then come back and continue to work, because there's a stigma associated with it, and we need to find a way to get rid of that stigma for people so they feel comfortable walking around and wearing their oxygen, because it really does benefit them. You know, it decreases the strain on your heart if you're exercising wearing your oxygen. You're actually causing yourself a lot more trouble and a lot longer recovery time if you exercise without it. So the benefits are they teach you breathing techniques, ways to recover, ways to do what we call pursed lipped breathing, where you kind of stall and you push that air back out, and it helps you to recuperate and recruit alveoli when you're breathing. It helps you to come back faster. So, and the key to remember when you're doing pulmonary rehab is it's not a competition. This is a way to improve each person's individual lifestyle. So whatever the patient's goal is, that's what they're working towards. You're not trying to beat everyone else or show that you can exercise with absolutely, no oxygen, and I can go 20 minutes and, and really wipe myself out for 3 days. It's a nice pace, a nice steady race, but it's very beneficial and very helpful for patients. So don't leave it off. Please exercise with it, and pass that word along to all of your patients, if you see them. It's good for them to wear oxygen. Some of the facilities will have oxygen there. Some will make you wear your own portable device when you do your initial screening at pulmonary rehab. They'll discuss that with them. They'll ask them, if you have a portable concentrator, what the liter flow is, and they verify that with that 6-minute walk from the physician to know. Even patients who are on 8-10 liters of oxygen can go to pulmonary rehab. So please don't let anyone be deterred from going. And again, there's my reminder, it takes longer for your muscles to recover, and your heart works harder. Your heart doesn't slow down as well if you've depleted it of all the oxygen. So be kind to your body, it's the only one you have, and use it to the best of your abilities. Here are some references for different places you can look up. The American Thoracic Society has guidelines for pulmonary rehab, and there's listings in every state, in every city. And you can also, nowadays with the internet, they can read reviews of the pulmonary rehab centers and find out if patients were satisfied there, if they like it, if it's a good quality staff, if they get a lot of interaction. But it's one of the best things that I can recommend for people to do. And then, thank you.
So I'm going to be talking about everybody's favorite subject, oxygen. Yes, so I have nothing to disclose. My objectives are to talk about how you qualify for oxygen, the different oxygen devices, and then the difference between pulse and continuous flow. Currently, there are 5 million adults living with chronic lung disease in the United States, with more than 1 million prescribed long-term oxygen therapy. So per Medicare guidelines, in order to qualify for oxygen, the test must be done in a chronic stable state. If you're outpatient or in a clinic setting, it must be done within 30 days of that order. But if you're inpatient, it's important that it is done within 48 hours of discharge, otherwise insurance will not accept it. For group 1 patients, which are most are ILD patients, the order is good for 12 months, but our group 2 patients, it's only limited to 3 months. So our group 2 patients are the patients with dependent edema, which suggests CHF, pulmonary hypertension patients, and patients that have hematocrit greater than 56%. So oxygen saturations must be less than 88% to qualify for oxygen. First, the patient is tested at rest. If it is less than 88% at rest, they automatically qualify. If not, then we ambulate our patients and see what liter flow they need to keep them at 88% or higher. So most facilities do what's called a 6-minute walk to qualify our patients for oxygen. This is a test that measures the distance that a patient can walk quickly on a flat, hard surface for a period of 6 minutes. Normally, every 3 meters are marked for the patient, and then the turnaround points are marked with cones. You should have a 100-foot hallway to complete this test, and we recommend that patients wear comfortable clothes and walking shoes. We also recommend no vigorous exercise within 2 hours of starting the test. Listed are just some contraindications if they've had unstable angina or a myocardial infarction in the past month. We do not recommend it. Relative is resting heart rate greater than 120, a systolic blood pressure greater than 180, or diastolic greater than 100. And then some reasons that immediately stop the test is any sort of chest pain, intolerable dyspnea, diaphoresis, or pale ashen appearance. We use a Borg scale prior to the test and after they're done completing it to grade their level of shortness of breath. The objective of this test is to walk as far as possible during the 6 minutes, but the patient must know that the time does not stop, even though if they have to stop for any reason at all. So ordering oxygen. This is the fun part. It does require a face-to-face documentation within 30 days of that order, which includes a primary lung diagnosis and any hypoxia-related symptoms. You need to either include a certificate of medical necessity or a written order. And it's very important, if your order is not written correctly, the insurance company will not accept it. So it must include the method of administration, which is normally just a nasal cannula, the frequency of use, which we normally just put 24/7, and the length of use, which is usually 99 months. And then any of the qualifying testing that shows how much the patients do need. So let's talk about the different oxygen devices for our patients. There's compressed gas, concentrators, and liquid oxygen. So compressed gas are your tanks that you normally see. They come in all different sizes. They can range anywhere from about 2 pounds up to 7 pounds at an empty weight. Some can be refilled by the patient, and then they have gauges on them that allow the patient to adjust their liter flow based on their needs. The size of the tank and the liter flow will determine how long these oxygen tanks do last. That's usually the patient's biggest complaint is, I have to bring 3 or 4 with me if I go out to do something. These are not permitted for air travel either. So this is just a little chart that shows how long these different tanks will last dependent on the liter flow. So for example, our E-tanks at 1 liter will last 10 hours when they're full, but at 4 liters, they only last about 2.5 hours. And then the D-tanks obviously are smaller, so they don't last quite as long. Home concentrators. So the home concentrators draw in air from the surroundings. It removes any nitrogen or other gases and delivers purified oxygen to our patients. It does deliver a continuous flow. It does require electricity. So living in Florida, hurricane season, a lot of companies will provide the patients with like backup tanks in case they lose their electricity. And then they are usually available in 5 and 10 liters per minute. Portable oxygen concentrators are what most of our patients request and ask for. A lot of times these can be on back order and take a little time for our patients to get, but they're easier and smaller to use on the go. They can weigh anywhere from 3 up to 22 pounds. They can deliver continuous or pulse flow. So most oxygen, portable oxygen devices will deliver about max 3 liters continuous flow or a 6 pulse flow. It can be powered by electricity or rechargeable batteries, and these are approved for FAA approved for air travel. Most airlines just require a form to be filled out for the patient prior to them traveling. So liquid oxygen is compressed and cooled to a point where it does become frozen. It consists of a stationary unit that the patients use to fill up their portable tanks. The tanks can weigh anywhere between 3 to 11 pounds. A medium liquid oxygen concentrator or canister can last about 3 hours at 6 liters continuous flow. It can provide up to 15 liters, which is nice for our patients that are at the end stage of their lung disease that need that higher flow. The problem is the cost is about 4 times higher than compressed oxygen or POCs. So nowadays, a lot of companies do not offer liquid oxygen. It's hard to find for our patients. And of course, it's not allowed for air travel. So the difference between pulse and continuous flow, this is a big misconception that our patients, they're like, oh, well, I'm prescribed 3 liters, but they're using 3 liters pulse, which truly is not 3 liters. So pulse is delivered at a bolus of oxygen when the patient takes a breath in. It's more of a demand flow. It does allow for the tanks and the batteries to last longer, and the prescription is not in a liters per minute, it's in a pulse flow setting. Continuous, though, is where it supplies a constant, steady, reliable oxygen flow based on a liters per minute prescription. And it delivers oxygen even if the patient isn't taking that breath in. Okay. In my next talk, I'm going to discuss our support groups for our patients. So why should they join a support group? It provides emotional support. You can share experience, receive practical information, learn information from different healthcare providers, and discuss topics and concerns related to their disease. There's a bunch of different group topics, and every place is probably a little bit different, but some examples are clinical trials, oxygen therapy, pulmonary rehab, diet and nutrition, lung transplant, caregiver support, hospice, palliative care, and advanced care planning, and then patient-led discussions. The PFF actually has a good amount of support groups that are available via Zoom. Here's just a list of a few, but the PFF Voice is a chance to learn from healthcare providers and discuss topics and concerns related to the disease. PFF Caring Conversations are for the caregivers of patients with pulmonary fibrosis. It gives them an opportunity to share their experience and information related to their caregiver role. And then the PFF Lung Transplant Community Support Group are for those who've had or are awaiting a lung transplant due to pulmonary fibrosis. It provides the opportunity to discuss and dialogue around transplant-related challenges and celebrations. So I know a lot of places offer these type of support groups. Most of them we have one, but unfortunately it's still Zoom since COVID, but hopefully one day we'll get back into person. And those are my resources. And that's it. Thank you.
And we're going to talk about addressing the challenges of care in the interstitial lung disease, complexity of patient care, coordination of care, and medication. Apparently all in 25 minutes, hopefully. Let's see, the button, the green one. And here's my disclosures. I have none. And my objectives. While you're looking over the objectives, I do want to welcome all those that are here for their first time at the summit. I think it's an amazing experience, and I am certain you will take back with you new information, resources, hopefully some colleagues to reach out to, and hopefully some dear friends, which I have from the past. So to start this discussion, I wanted to go over the 6 T's of successful ILD management that Janelle Reichhuber and I spoke about several years ago. I wanted to review them with you today, as I feel are key in working to address the issues we will be discussing and essential in us being successful in the care of our patients with ILD. Treatment, trials, transplant, and transition have been talked about here in the non-session or will be discussed here later today or during the upcoming days of the summit. The T's we're going to focus on are team, talk, and the 7th T, time. When we look at addressing the challenges of ILD care, remember your team. Who is the team? Pretty much all those around us in our ILD community, in our local practice, your medical research assistants, nursing colleagues, respiratory therapists, pharmacy techs, just to name a few. Talk. We use this T often, talking with team members about a concern or issue with a patient, providing patient education, reaching out to local providers to get records, or even calling DMEs, finding options for the high flow oxygen options, if there are any, unfortunately. Through each of our days, we're communicating and reaching out to various members of our team, all on the behalf of our most valued team member, the patient, along with their caregiver. Time. Time can affect how we're addressing issues on multiple levels. The time to educate patients and caregivers, the time we need to make involved telephone calls, time as well as time we need to educate ourselves, such as attending journal clubs and being here in Orlando at the summit. Time, as we are aware, is also one of our greatest obstacles. The time a patient is waiting for an appointment with a specialist, or waiting for a call from the MDD, or waiting for that new drug research to be completed. Time has an impact on all that are involved with the care of patients with ILD, the challenges and complexities associated with it, and with this disease, and the patients and families who are on this journey. However, I believe if we can continue to count on our teams, reach out and talk with all those around us who take care of and care about the ILD patients, we can continue to work to address many of these challenges and find solutions. I did not want to finish talking about time without providing a small reminder. I believe we've all had days that are not going as we had hoped for whatever reason, volume of calls, trying to get back to everyone in a timely fashion, unable to improve a patient's oxygen issue, or the frustration of trying to find patient assistance for medications. It's essential that we take time for ourselves, whether that's going on a holiday for a few days, or even stepping away for just a few moments to regroup, as working through these challenges require us all to be engaged, make the time that will be needed both for issues at our centers as well as those through other organizations, collaborate together so we can continue to help our most valued team members. So let us start by walking through the journey many of our patients go through, which Susan had also spoke about earlier this morning. I think it's safe to say the complexity of care in the ILD realm starts at the beginning of the patient's journey, determining their diagnosis. I think we've all heard our patients say sentences such as, I thought I was more short of breath because I was getting older, I gained weight, or I'm out of shape. As well as so many of the symptoms are nonspecific, and when they are seen with these symptoms, their primary provider may or may not be aware of ILD and certainly can miss whatever part of the evaluation could potentially point to the ILD. I just met a daughter, actually at the PFF walk in Chicago, who mentioned her mom's primary care gave her an inhaler for her symptoms she was having. For a year and a half, her mom took the inhaler. Her symptoms continued. Her daughter finally said, Mom, we need to go to a pulmonary doctor. However, even when they went to a pulmonary doctor, there's also, or the primary providers aware or potential or concerned about ILD being a diagnosis, it still takes time to get the tests that are needed to determine what is going on. These delays are the first part or the start in the patient with ILD and the ILD journey. How can we improve this process and delays? Perhaps one answer is to continue to educate all on ILD and providers, from the providers to the public. I think we had a little bit of that mentioned when we were talking about some of our the rural program that the PFF is having, trying to get the word out. When I mentioned back to the daughter I had met at the PFF walk, she said by the time that her mom actually got a diagnosis, the treatment options were limited, and she got little education in the process, and she ended up finding out most of her information on her own. Her mom passed away, unfortunately, in 2019, and shortly after that, her dad had a diagnosis with a brain tumor. She said all she learned the hard way with her mom, she was able to kind of help take care of her father. She ended up taking care of him until he passed away, and she said now that she's been able to process everything she went through, she has decided she wants to help educate those around her to bring awareness for pulmonary fibrosis. She said everybody knows about cancers, no one knows about pulmonary fibrosis. She is hopeful she can prevent further delays and improve awareness so that no one else has to go through what her and her mom went through. And I'm certain we've all heard those stories. And even once an ILD diagnosis is made, many of our patients go through healthcare journeys educating providers about what they have. A patient mentioned to me recently, she was admitted for a non-ILD issue for several weeks, and only one of her providers even knew what ILD was. She actually ended up handing out education to the PFF to all those that took care of her. So that was helpful, hopefully. So what can members of the non do? Well, as I mentioned, the PFF has the rural work group that we had talked about just a minute ago, but I do really think that we can make sure that patients' healthcare teams are getting those follow-up letters that are written, perhaps even calling and talking with them. We have an opportunity, knowing full well these calls will take extra time, because every bit of knowledge sharing will be helpful. I know this has been an ongoing issue with many trying to improve ILD and pulmonary fibrosis awareness and education. We know we have the Pulmonary Fibrosis Awareness Month, so blowing up buildings, walks, picnics are all spreading awareness of this disease. And I've actually had several patients recently tell me they've heard radio spots on ILD in our area. I've not heard it, but they forwarded me on the link. So hoping with all the efforts being put in place, perhaps in time the stories of patients telling us about their delays in getting a diagnosis, or healthcare teams having no idea what ILD is, will no longer be an issue. Now, once the ILD is raised as a diagnosis, because of the nature of the disease, the patient's care is usually next referred to an expert center, both due to the complexity of the disease and the expert center's potential for diagnostic accuracy. Unfortunately for the patient on this journey who just had a delay due to their nonspecific symptoms, getting local testing, they're now waiting for an appointment at the center. And besides the time in waiting for these appointments, which can take weeks or months, unfortunately, there's the issue with the location of these centers. You know, a patient could live many miles away from the center, and how are they going to get there? And even once seen at the expert center, the team may require updated testing, or perhaps the patient shows up and says, oh, my testing should be here, but there's no scans, no testing, and all that does is make for a very difficult visit, and there's really no meaningful information being taken away at that time, and of course, more delays for the patient. And as noted, unfortunately, delayed access to these centers has been associated with increased mortality regardless of the disease severity. I know there's recent work to improve some of these geographic issues. The PFF has added the clinical associate members to the CNN, which can certainly help expand the volume and location of expert centers across the states. We have seen an increase in virtual and telemedicine visits, although I know many still do not have the access or ability to complete some of these visits due to resources, computer knowledge, as well as how the billing and insurance requirements can affect who and where a visit can be done. Now, after the testing and evaluation at the expert center is complete, the next step for most is to confirm a diagnosis at the multidisciplinary discussion. Although from our recent Mobilize thread, I think who gets presented may be dependent on each center and the provider's evaluation of the patient and their tests. But for many patients, to confirm a diagnosis, the next part of their journey is presentation at the multidisciplinary discussion. Now, we know this discussion is an integral part of expert centers, a process to confirm a diagnosis, yet many times time is a factor in the discussion. Time that may go by as we wait for outside images or slides to arrive and be reviewed, time that is allocated for these meetings, which as noted previously may lead to team having to determine who may need to be presented and who may not based on their history and testing. And even when patients are presented, it is noted that 20% of patients get the label of unclassifiable ILD. So now if they have a diagnosis confirmed and a patient aware of their diagnosis, potentially unclassifiable, this is a time I think it's important for the ILD coordinator to be present. I'm hoping in your centers you have some type of system where you're able to follow up with the patient after these meetings to go over starting new medication or perhaps additional testing that they may have. So that you can kind of go over with them the diagnosis and help them understand their diagnosis, answer any questions, which we know can certainly be an issue with their alphabet soup of medical terms that are thrown at them. And then, of course, besides these terms, they have a whole slew of extra tests, referrals, and to other specialists. With all this, it's crucial to figure out, of course, where the follow-up will be done, who is ordering and following up on the recommended studies. And as mentioned, since many of these care center networks are a distance away, some folks may return to their local pulmonary team, so it's really important to make sure they get the follow-up recommendations in a letter format, and if you're able, perhaps even to call those centers. We've also had some patients who end up with a virtual or video visit and follow-up, but all their testing is locally. This can certainly help another set of separate sets of challenges and complexity issues, as we often end up spending time trying to obtain all these images and follow-up tests to get to the provider to review. But I think that's a balance to help the patients who may live a distance, unable to travel, or even have issues with their oxygen needs. Certainly gives them the ability to still be seen in an expert center without the extra stress of travel. And of course, many patients will continue to receive all their care at these centers. But throughout this process of determining where follow-up care will be completed, we need, if able, to always strive to provide any resources and education we can, even if our time with that patient is only limited to one visit. So now that an official diagnosis is made, or diagnosis at this time is made, follow-up care set, what are the next steps these patients go through? Well, as a reminder, it's important to let patients know that there's no one-size-fits-all approach for management. It needs to be tailored to fit specific needs. And treatment options, as we know, can vary from patient to patient. Of course, some of those treatment options that are available are limited in what they can do and what many wish they did. We'll go over this a little later, but we know the antifibrotic meds help slow progression, yet many times the reason why a patient sought treatment from a provider was for a cough, fatigue, or dyspnea. And the lack of supportive care. I felt a little defeated when I read in multiple studies patients' concern over not getting enough education, resources, as well as lack of communication. I've been fortunate to have met several amazing folks recently through various activities with the PFF, and even though I spend almost all my working hours with patients with IPF or ILD, when you step outside your healthcare setting, it does bring a different perspective. I'm not really sure why. Maybe I'm so focused on their symptoms and follow-up care, I don't routinely ask them how we could be doing better. Certainly something I need to do. And we know there's resources out there, so we do not need to reinvent the wheel, but I do think we need to figure out a better and improved way to produce and share those resources. And then lack of psychosocial and emotional support for patients and caregivers, the stress, fear, and anxiety that are felt by both, as well as the loss of independence with issues with activities of daily living. And perhaps some of these issues can be helped by improved self-management strategies, helping to give them the ability to understand what is going on, what they should be concerned with, as well as help them make the best decisions for themselves. I'm hoping many of you got that email for the Delphi study on this issue, self-management, and were able to respond. With mentioning research, there is so much coming out so fast. We really need to help the patient understand the clinical trial process, and we know that the time factor can be difficult for many to acknowledge. Why do the answers to research studies take so long? And as research continues, it's necessary to make sure there is a focus on improving race, ethnic, and gender disparities. For those that have any thought on how that can be done, please share. My one thought is making sure to spread the word on the PFF community registry as a start in hopes of getting a diverse mix of patients and caregivers. Some ways I thought to address these issues, my cystic fibrosis colleagues have a QI meeting with a patient representative so a patient's voice is heard. I know the PFF has representation, but certainly looking to see how I can do that into my center, as well as about patient advocates. Perhaps some ways to help the patient through the diagnosis and next steps is to have an advocate or a mentor. Our group started to look into this after reading how patients thought it would be beneficial. We are in the very early stages, so I do not have much to share. Certainly if anyone does have a patient advocate program or any kind of a group QI meeting with patients in their centers, I would love to meet with you after. The ILD coordinator is there to assist patients through the next steps after diagnosis, and part of those steps is helping to coordinate their care. And I think it's safe to say that part of the overall complexity of ILD diagnosis is the coordination of the care that's needed. So what is involved with coordination? Well, communication is described as the main coordination component that is used between multiple team members. And if we add the ANA White statement here, even though for nurses, I think it can go for any of the team members, care coordination can also help with patient safety, increase confidence in self-management care, and improve all over patient satisfaction. So what do I see when I think of care coordination in the ILD realm? Well, something like this. We have the patient and caregiver in the middle, and then all the other potential specialists that they need to see and testing. And certainly not all patients are going to need to see all of these folks, and I may have even missed some, but we know, unfortunately, with the progressive nature of the ILDs, their needs will change as they continue to deal with their diagnosis, and additional testing and coordination will need to occur, perhaps including all of the above. It's also important to remember, I know a few have mentioned this, that many of these patients have other medical problems or seeing other physicians. So we're trying to incorporate that along with everything going on with their ILD, and they have their ILD symptoms and their potential side effects of medications. And of course, some are still continuing to want to do the things they enjoy, travel, hobbies, sports, as well as be with their friends, families, work. I do feel the ILD coordinator is crucial in assisting with these many needs, but we need to count on all members of the patient's care team. Here's if I give a shout out to one of our research assistants. She ends up seeing almost all of our ILD patients for a research study, and she'll come up to me frequently and say, Mr. So-and-so, I think would benefit from your support group. Can you talk to him? And I feel if she did not mention this to me, that patient could have missed that extra support he or she may have needed. The team working together for the patient to help them through all that is involved with evaluation, testing, and treatment. In the middle of all this, also helping to be an advocate for the patient, helping the patient be an advocate for themselves. So what can help us as we coordinate the patient's care? Well, I'm going to kind of go back to the beginning. Super important. Much of coordination involves having your other team members help you and help the patient achieve the expected outcome by communication, which we all know can take time. Scheduling tests, follow-up from other specialists, or even lab monitoring. I at least say frequently to a patient, I don't want you to go through this journey alone. In the same manner, you shouldn't feel you're alone as you try to coordinate the patient's care. I'm hopeful if you don't have anyone that works with you, you can go back to your management, see if there's someone that can help you, or even reach out to some of your local providers. Maybe they can, you guys can work together to help each of the patients. And of course, EMR it's considered definitely, I think it could be considered a part of our team. However, because it's one way to support the communication across the patient's journey. Unfortunately, as we know, there's different kinds of EMR systems. I just wish they all could talk together. That would be wonderful, as well as radiology images. It'd be fabulous if someone could go to their home center, get their HRCT, and we could see it right away, maybe someday. Now, thinking of future coordination directions, besides hoping to get CAT scans shared, I do ask the patients to report concerns with their pulse ox numbers, even with the known issues of those with darker skin tones. I still encourage my patients to keep track of that and get an idea of what their normal is, and kind of let me know, especially if there's changes with that, along with their other symptoms. And of course, there's many new devices out there that monitor patients' oxygen levels for over 24-hour periods. So further research needs to be done so we can use this data to help patients in the outpatient setting. And if we can use that data and then maybe have a virtual visit with this pulse ox and a home spirometry use it, which I know my CF colleagues use, what could we do with that information? Well, I think I am aware that these home studies need to be studied further, along with the patient's ability to use them. But if perhaps we make a call and we see that their oxygen levels are low, maybe their home spirometry numbers are lower, maybe we can help address an exacerbation ahead of time, get them to the hospital, get further testing, prevent worsening of their fibrosis. I know I'm thinking big, but I do think this very well could be something in the future for these folks. And as we look into the future of care for ILD, focus on medication used to treat the ILD population certainly is needed. Because I do think one of the bigger challenges that we need to look at is that the medication for treatment doesn't really treat, doesn't really treat the symptoms or the quality or improve any quality of life. It certainly can make it difficult to talk with patients and discuss these medications as well as what they are designed or rather not designed to do. I do think when you're talking to patients about medications, this is the conversations you also want to talk to folks about some of those non-pharmacologic treatments, like pulmonary rehab, as we spoke about, and of course, make sure palliative care is mentioned. So I'm going to spend a little of my time left talking about antifibrotic medications. As for me, these are some of the meds that are hardest to go over with folks, helping them to understand what they're designed to do, or rather not designed to do. And this is kind of hard, these discussions, to kind of talk with the patient, determine what do they want. The potential treatment options available can lead to many questions. And even our folks already on medication, you have issues with side effects and, of course, quality of life issues. There's many shared decision-making points along the patient's journey. I feel discussing antifibrotic meds is one of the more involved discussions. And if you look at Cage et al., shared decision-making, they spoke of 5 elements of patient readiness of shared decision-making, which can include understanding of shared decision-making, health literacy, and skills in communicating. And then some of the 10 characteristics that influence the elements of this readiness include cultural and educational backgrounds, emotional distress, acceptance of diagnosis, relationship with clinicians, and my friend time. So discussion of these meds, being able to spend time to go over with the patient options they have, if they have a choice, how to take these meds, eating with protein, and when they do have issues on their meds, what can be done to help, working on slower titrations, taking a drug holiday, lowering the dose, changing medications, making sure you have a food diary. All these discussions are done to help improve, hopefully, quality of life, so the side effects and the quality of life, and help them be successful and compliant on their meds. And we know these conversations take time and are best if they can be done when the patient has a relationship with the ILD care team. What we do know is being able to work with your patient to be successful and compliant is to take advantage of the advantage, which is patients with IPF who received antifibrotic meds were noted to have improved survival. However, in saying this, nutrition and weight loss can affect outcomes, so we really need to continue to evaluate patients' nutritional status on these meds or starting these, which I know is an issue. It sounds like not every location has a nutritionist to rely on, because they have noted such folks as patients on pirfenidone who experience a greater than or equal to 5% weight loss in a year experience worse outcome compared with patients that maintain their weight. And that's for Juno et al. So reaching out to your dietitian early on may be best for patients, although it's kind of hard if you don't have a dietitian, so hopefully that's something that can be addressed. I do think there's a tremendous amount our patients deal with along their ILD journey, and as an ILD coordinator, any member of the care team dealing with all the complexities associated with this disease, working to coordinate care and the medication issues, here's your last reminder. We need to rely on each other, reach out, ask questions. I cannot tell you how much I have learned from the questions that have come through Mobilize recently as an example. And I think we're all aware of not only the time that is involved in these processes, but the time we need to invest to address them, whether at our centers or together at the non. And this is just my challenge to you all. Just some ideas I have. Certainly, if you have some, please reach out. I do think this group is a group that started in Nashville several years ago, and I think we have a lot that can be done working together. And here are my references and my thank you, which also shows where I go when I try to regroup. So, thank you all.
Well, thank you so much for asking me to speak today. It definitely is an honor to be here. Today, we're going to talk about transplant and interstitial lung disease, and how we as nurses and nurse practitioners in allied health are part and can partner with the transplant team. We'll cover a lot of information today, but we'll try to keep your attention. Since we're right before lunch, I know people are eager to do that. Like mentioned, I work at Henry Ford Hospital in Detroit, Michigan. We're a very large and busy ILD center, and we work very closely with our transplant team there. I get to see patients in clinic every single day in the outpatient setting, but I also get to see our inpatients as well if they are admitted into the hospital, since we're all connected kind of in the same building. So I'm able to see patients before they have a transplant, and then I can kind of also follow them along their journey if they do get a transplant and see them for a little bit after as well. And those are my disclosures, which I don't have any. Okay. As far as what we're going to talk about today, we're going to cover a lot of material this morning, but here's just a little brief outline of the main topics I want to talk about. Of course, introducing lung transplant, referral and evaluation, the workup, wait list and readiness, and then what happens after transplant. Introduction to lung transplant. It is an effective treatment for certain selected patients with end-stage lung disease. And it involves surgery to remove a damaged or diseased lung and replace it with a healthy lung from a deceased donor. It's a life-saving treatment for people with late-stage lung disease and after all other treatments have been exhausted. Studies have demonstrated that lung transplant is associated with a significant improvement in quality of life. Lung transplant, though, continues to face a lot of challenges, such as imbalance between donor supply and demand, and the fact that survival after is still behind that of other solid organ transplants. So here is, on a slide, you will see a diagram of a lung transplant where the donor lung is being attached at the recipient lung there. You can see it's attached at 3 different areas: the bronchial, pulmonary artery, and left atrial attachment. Okay. So there are always ethics involved with transplant, of course. When we think about those, we just have to keep those in the back of our mind. 3 of the main ethical issues are utility, justice, and respect. So the utility and why is to maximize the net benefit. For example, using years of survival gained to prioritize the allocation. For the justice of a lung transplant, it's really to distribute the benefits and burdens of organ allocation system in a fair way. So they use medical urgency to prioritize allocation, and they allow special considerations for candidates for whom it's difficult to find a suitable organ. And as far as respect for persons, so to treat people autonomously with the right for self-determination. The 2020 consensus statement, just to give you a little bit of background on that, it was an international group that reviewed literature, or the current literature, to consider the recent advancement in the management of lung diseases and to update the documents on the selection of candidates. In that, it's a really interesting document if you want to take a look at that at some point. It did say in there that lung transplantation should be considered for adults with chronic end-stage lung disease who meet the following criteria. So the first one was if they have a high risk of death from lung disease within 2 years, which is greater than 50%. If the lung transplant was not performed, they would be considered. And with a high likelihood of a 5-year post-transplant survival from a general medical perspective, provided that there is good graft function. ILD referral, it's a really complex process, honestly. I think it can be, introduced very early in the process of diagnosis, and that's what really that they want us to do, is that they want to refer and do the workup very early, before the need for transplant becomes urgent. We often talk to our patients about it during a clinic visit very early on. And you know, it might be kind of scary to bring that up when you're first meeting a patient, you know, to say, oh, lung transplant is something that we're looking at for you. But I have found that most people are really open to hearing about it, and they actually want to hear. I haven't had many patients who say, I don't want to talk about it. There are some who say, oh, let me go home, talk to my family about it. I'll let you know next visit or something like that. But they really are usually very interested in learning, especially early on. So they should really be referred before they meet criteria for active waitlisting to provide an opportunity to introduce the concept of lung transplant and all its requirements and expected outcomes. And so if they are referred early, it also allows like a little bit of extra time if they need to overcome certain barriers that they have, such as comorbidities and inadequate social support, or if they need to like lose a little bit of weight and that kind of thing. So that gives that opportunity for that. Let's just pause here and talk about a case study that I seen a few years ago. So there was a 58-year-old male. He was a former smoker. He was diagnosed in 2015 with IPF. He was from another hospital, not too near us, but maybe a couple hours away. So he was diagnosed there. They sent him down to us a few years later in 2017 because he had a lot more shortness of breath. So he had acute dyspnea. He was on steroids for a month prior to that, but just kept getting worse and worse. So they transferred him down to us, and they wanted a lung transplant referral at that time. While he was in the hospital then, he was treated for pneumonia, and they had him on steroids and that. They tapered that off, and he was doing okay. You know, he was offered antifibrotic, but he declined that medication because he was really concerned about the side effects. So he declined that, but we continued to see him in our clinic. He continued to do pretty well. He was on a little bit of oxygen, and he was very active, you know, in his around his yard and his house and all that kind of thing. But then he started needing a little bit more oxygen, a little bit more oxygen. He was also following with the transplant team at this time. And they were also seeing him simultaneously with our ILD team. So it started to require up to 8 liters on exertion. So he ended up getting a lung transplant in 2018. He was listed for transplant in 2018, and he received the lung about a year later. Was only in the hospital for a short time, was discharged home, and is doing very well up until this day, you know, living a very healthy and active lifestyle. And the best thing about it, of course, is that he wasn't on oxygen anymore. So transplant and IPF. IPF in the past, you know, we always read that it carries a very poor prognosis, 3 to 5 years of survival after diagnosis when untreated. We've seen that to be extended lately because of antifibrotic medications, of course. That's been shown to reduce, you know, FVC decline and slow progression of disease, and as well, you know, limit the number of acute exacerbations. But still, it is associated with a very high mortality rate. So because it's so unpredictable, it's really still advisable to refer the patients early with IPF for lung trans evaluation. And then with other interstitial lung disease, they may require special consideration, you know, including people with familiar fibrosis, ANCA-associated vasculitis, sarcoid, and other connective tissue diseases. Connective tissue disease-related ILD was previously thought to be a contraindication for lung transplant in some places, but many patients with it are now undergoing successful transplants. So the people with connective tissue disease ILD are considered for evaluation on a case-by-case basis, and it depends on a lot of different things, depending on the transplant center and the health of the patient as well. So to be aware of the evaluation that's needed for transplant, all organs and systems functioning fairly well. Adherence to medical care. It's very important for the patient to be showing up for their appointments, up to their visits, taking their medications, and taking all their tests and everything that's needed. That's an extremely important factor. Up to date on their vaccinations, of course. their checkups and their dental care, be able to exercise, participate in pulmonary rehab, a BMI within a certain range. So usually like 19 to 32-ish is the range that we kind of tend to take a look at. Free from narcotics, illicit drugs, alcohol, and tobacco free for usually about 6 months. And then also having a really strong support system to have a couple of people, 2 to 3, that are able to help them and be very supportive for them through the process. Let's talk about another case. This one is a 72-year-old lady, diagnosis of RA-ILD, rheumatoid arthritis-related ILD, previously on quite a few different medications, methotrexate, hydrochloroquine, sulfasalazine, rituximab, on intermittent steroids over time, and then currently was on azathioprine. So having a little bit of a difficult time getting the medication that was working for her. She was, of course, on oxygen at 6 liters at rest and up to 10 liters on exertion. This patient had a couple of barriers, which was a BMI that was a little bit high, and the transplant team needed her to lose a little bit of weight before they said that they would list her. Even though that she was on 10 liters of oxygen, she was still going to all of her appointments by herself, going to rehab by herself, driving herself everywhere, just really pushing through to try to get to that, try to get listed. And she was actually able to lose the pounds that she needed, and she got down to an acceptable BMI, was really hoping to get listed for transplant, but she unfortunately recently was admitted and had a kind of a flare-up in her underlying autoimmune disease, so is not able to be listed at this time. But the ILD team is working very closely with the patient and also with the transplant team to try to control her underlying disease and move her towards the goal of hopefully still eventually being listed soon. So, so we really hope that she continues to do well and gets a little bit better that way. Now, what is involved in the workup with a transplant, pre-transplant? There's a lot of things that need done. I think just that we're aware of it. We may not be ordering all of these tests. The transplant team probably will be, but there are some things that we order too. PFTs, of course, oxygen dose, 6-minute walk, chest X-ray, CT, stress test, echocardiogram, right and left heart cath, bone mineral density test, blood work, blood gases, blood types, antibodies, screening for certain infectious diseases such as TB, HIV, hepatitis, et cetera. And then they need to be up to date on their screenings for age-appropriate cancers, so colonoscopy, mammogram, that kind of thing. Those type of tests, we often just tell our patients, you need to get those done, go to your primary care doctor, make sure that you're seeing them, make sure everything is kind of up to date, just to kind of ready yourself for that. And then screening for reflux, we talked about that a little bit earlier, and esophageal movement. So there's a long list here. We'll go through these ones. It's absolute contradictions for the most part for lung transplant. So one of the big ones is if patients doesn't want a transplant, obviously, or if their lack of willingness to accept the transplant, they're not going to be someone that would be listed. Malignancy, usually they need to be within 5 years of malignancy before they're considered to be listed. And GFR, acute coronary syndrome, or MI, within the last 30 days, stroke within 30 days, liver cirrhosis or liver failure, unless they're going to be considered for multi-organ transplant. That could be something that could be looked at. Renal failure as well. On dialysis, not likely to recover. That would not be looked at. Septic shock, active infections, limited functional status. So someone who would not be able to do pulmonary rehab after transplant would not necessarily be considered. Cognitive impairment, not adherence. We talked about that earlier. So if someone isn't adhering to their tests, to their appointments, taking their medication, those would not normally be looked at. Active substance abuse or use of that kind of, any kind of drugs, that kind of thing. And then other severe medical conditions. Now the next slide talks about just risk factors that are high risk. And these things may be considered at certain centers, so it's not an absolute no, but at certain centers may have different expertise in certain things, so they may consider things such as over age 70. I've seen patients transplanted over 70 to do very well, but it just depends on the institution. Severe coronary artery disease, sometimes they're able to go in and do a bypass during the transplant, so that can be looked at, but it is higher risk. Esophageal dysmotility, so at times if they have esophageal dysmotility, they will be told that they'll need a feeding tube, during the transplant process, and it may be for a little while after, or it may even be permanent. So some people are fine with that, and they say, like, I can handle that, I can even handle a feeding tube for the rest of my life, and they say, go ahead. But some people cannot, and they just say, no, I'm not gonna go through with it because it's just not quality of life. The BMI is something that is, if it's too high or too low, it's associated with poorer outcomes. And so, they need like I said, they need their support system. So if they don't have one, and I have seen many patients go through a transplant evaluation, and they say, I don't have anybody here. I don't have anyone that's gonna help me, and so it's just off the table for them, sadly. And then certain infections, things like that. So we won't go through that entire list, but you can see that there are a lot of high-risk factors, and then some of them can be modified, so people can work on some of these things and then eventually be listed. Now, extracorporeal membrane oxygenation, or ECMO, or life support, is a bridge to transplant. Just wanted to mention that really briefly, that there are patients who, of course, are put on ECMO in the hospital setting. Generally speaking, when I've seen this will bridge them to transplant if we know the transplant could be coming soon. But they usually have to be awake and alert and still able to move around and still able to participate, like in getting out of the bed and that kind of thing, and stay strong for their upcoming pending surgery and transplant. Wanted to briefly mention United Network for Organ Sharing, just to mention what it is. It's a nonprofit charitable organization that serves as an organ procurement and transplant network that all of the centers participate in. And so the LAS, or the lung allocation system or scoring, it's a very important factor in determining priority for receiving a lung transplant when a donor lung becomes available. So it's a system that determines the order of waiting for a lung transplant by a score, blood type, and the distance between the candidates and the hospital where the lung donor is located. So it's a score of 0 to 100, and medical information is used to calculate this score for each candidate. You may know that there are differences in transplant centers and wonder why this is the case. So differences in candidate selection practices among centers are actually expected. Everyone will be fairly similar, but there are also a few differences as well. Centers have to take in consideration local circumstances and what is going on in that particular area in their particular city. So some centers will continue and be willing to accept a greater risk, depending on what they're kind of specialized in that area. And if there's more organ availability as well in their area, they may do higher risk patients. And then with doing this, they're able to develop more specialized expertise, and they can share that information with other transplant centers, and that will help advance the field overall. Now, we hear about the wait list, and we see our patients in clinic, and we know that they're listed for transplant, and they're waiting, and they're waiting, and they're waiting. But the average time for patients with IPF is actually 3 to 6 months. The first case that we studied, he waited a year. We have seen patients wait for several years, honestly. We've seen a patient just last week who had already been waiting for over, I think, a year and a half with IPF. But it's all dependent on how advanced the disease is. At the time of listing, they can wait for a couple of days, or they can wait for, like I said, years, depending on their score. Also, if they have a rare blood type, or if they're really tall, really short, or if they have different antibodies, it may take quite a bit longer to find a suitable match. As far as a readiness for a lung transplant, it might be, this will be discussed with the patient by the transplant team actually, but I think that, you know, as working with ILD patients, we still need to let them know this as well, just to kind of keep it in the back of our mind, that they must be able to travel to the transplant center within a specific time, usually a couple hours or 2 to 3, depending. They also may be required to relocate closer, depending on how far they live away. We've had patients that, you know, we eventually referred to a different center, like maybe 6 hours from us, and they ended up living down there for the time period, and that's what they want to do, and they're able to do that. But they also need to remember to answer the phone and voicemails, no matter who's calling them at all times. So just, you know, to remind them of that. If they don't recognize the number, just make sure you answer the phone. Because if they can't get a hold of you or the patient, they may move on. Okay. So just a little slide about, we're not going to get into the details of surgery, but the single lung can take 4 to 6 hours, and the double lung 8 to 12. And that can be longer depending if they're doing other things as well. So what happens after transplant? So it's definitely not an easy path. And 2 major issues facing transplant are rejection and infection. So I think, you know, patients need to know this before, and usually they do. Of course, they're going to be on immune suppressing medications. A third develop acute cellular rejection. The peak time to develop the rejection is around 6 months post-transplant, but the highest risk is within that first year. And surveillance bronchoscopies are done within the first year after transplant quite frequently. So what are the outcomes of transplant? Approximately 80% of lung transplant patients, 80 plus, survive at least 1 year. 74 are still alive after 3 years. There are many factors that contribute to survival post-transplant, including age, disease type, and severity of illness at the time of transplant. And so we'll pause and talk about another case. This is a 31-year-old female diagnosed with a connective tissue disease, ILD. We'd known her in our clinic for a number of years. In the beginning, she was only on a little bit of oxygen. She was actually doing okay. She was on myfortic and low-dose steroids. So as time progressed, she got worse and worse, and she ended up needing 15 liters or a non-rebreather when walking around. Our team, the whole entire team, really fought for this patient because she was one reason, she was very young, and she also had young kids as well. So we were really, really hoping for her to improve. So she needed 100% non-rebreather to walk around. Despite this, she was still going to rehab every week on non-rebreather. She was still really, really trying. She had a terrible cough one day when she came into clinic, so we ended up admitting her. She was just getting worse, so she was admitted for hypoxic respiratory failure, and during that admission, she was listed for transplant. She just developed worsening pulmonary hypertension while in the hospital, and then our team worked together very closely with the pulmonary hypertension team, the transplant team, and we got her on ECMO, actually, to bridge her to transplant. It was really a difficult time. She had multiple problems while in the hospital. She was taken off the list temporarily due to things that happened, then she was put back on, and then, taken off eventually in the end. Unfortunately, she passed away before a lung came to her. It was a really sad case. It was a really difficult case, and why I tell you about this is because this is part of our everyday. We see the downs and we see the ups. But I just also want to remind you that there are also many patients who have successful transplants as well, and they go on many, many years living, a normal life after struggling with such a complicated disease. Also wanted to mention that it's okay if a patient says no. You might bring up the idea of transplant to them, and you really think they should go see the transplant team or have a lung transplant, but they say no. I had a patient actually who said, you know what, I've lived a really good life. I want that lung to go towards someone who's much younger and who would need it more than me, kind of thing. So that kind of thing you will hear. As nurses, though, we can be advocates for all of our patients. We can give them the information, like some of the stuff we discussed today about transplants so that they're informed. We can communicate with the transplant team as well, and be part of their team, even though we're the ILD team. And we can be part of that support system for patients throughout this entire process. And so those are my resources on the last slide there. And thank you very much. That picture there is a lake in northern Michigan. Thank you so much for listening today.
I need some sunglasses up here. So thank you for the invitation and an opportunity to speak with all of you about what I really want to describe as a journey, not one that I ever planned on. And sometimes the good things in life happen that way. But it really also, I'd like to highlight along the way the various options for all of you to get involved. Again, this is something I wasn't intending to do, but the patient-driven need really sparked that passion. And that's really the only reason I could keep it going this long, is really for what our patients really drive for us. I have no conflict of interest. So I've kind of divided this into 3 areas. And I've noticed my timer's not started, so hopefully that's going. I'd like to talk a little bit about how the journey began in terms of identifying the problem and what we did actually to gather the data to kind of define the problem. The second portion, I'll go through how we identified who the stakeholders were. I mean, who were we advocating for? And it turns out there's many, different stakeholders that needs have to be addressed. And then lastly, really talk about the collaboration, which has really been awesome. There are people in this room that have been involved. It's crossed, as you'll see, many, many institutions, foundations, patients, industry, federal regulatory agencies. It's really been an impressive one. And of course, my picture here says it all. We're really looking for portable oxygen. This is a patient who arrived to our ILD clinic, and he really wanted to be able to use his walker and not have to deal with taking 2 E-tanks because he was on high flow. So his engineering friend built him a little platform there. So I thought that was pretty innovative. So this story began in the American Thoracic Society. I'm not sure if you're all aware of the interest areas. There are assemblies throughout the organization that represent all different interests. So there's clinical problems, there's behavioral science, there's vascular disease. Some are very bench related, some are very clinical, some are health policy. But there's a nursing assembly. The ATS, if many of you know, meets annually. This is a meeting of anywhere from 15 to 16,000 physicians mainly, clinicians, researchers, and nurses, probably around 200 or 300 nurses out of that group that meet annually. And the nursing assembly is small but mighty, and there's a planning committee on there. And in 2015, I chaired that committee, and its role is to identify areas that the nursing assembly should address, whether it's educational, advocacy, scientific research needing to be done. So at that meeting in 2015, the hallmark of the meeting was really all the nurses there. It was a small group of us complaining about the oxygen issues. We were all inundated at that time with an increasing amount of calls from patients and just having really incredible barriers to them getting quality service. So we established an oxygen working group, and the goals of the group were 4, providing clinician education, patient education, addressing payer and service issues related to Medicare and reimbursement, and identifying gaps in research. So to that end, at the next international conference, which was in San Francisco in 2016, we invited representatives from multiple advocacy organizations, 2 Medicare ombudsman representatives, ATS health policy, government affairs, patients, nurses, American Association of Respiratory Care. And the conclusion was the need for some objective data to document the problem. In 2016, we developed an online survey because we needed data. There was nothing published about the quantitative aspect of who was reporting the problem, how often, and what type of the problems. So we developed an online survey, went through the Stanford IRB, had a methodologist review it. We got IRB approval, and we released it for 6 weeks online. And this was published in the Annals. And we had outstanding representation across the US. Almost every state was involved. And it was very standard throughout the US. All areas reported about 50% responding yes to the question, do you have problems with oxygen? Our sample was 1,926. 43% reported their portable systems limited their time outside the house, either frequently or all the time. 35% reported being either very or somewhat unprepared to operate their equipment, even after instruction. And you can see the breakdown population. And I think this is something that keeps coming back to us. Oxygen crosses so many populations. It crosses pediatric, home ventilator, adults, critical care, every type of disease. So it really makes the problem much more significant. One interesting question we asked, how long does your portable oxygen last for you to be outside the home? And how long would you like it to last? And you can see in the red, the majority of patients had about 2 to 4 hours of portable oxygen outside the home, whereas the great majority wanted 5 to 6 hours. So a huge discrepancy there. And the types of problems, and note that patients can choose more than one answer, and most of the patients chose 3 or 4 of these answers. So the overwhelming one, these are for patients who said, yes, I have a problem, was equipment not working. That actually surprised us. I was unaware that that was such a common complaint from patients. And then the usual, travel oxygen problems, delivery, multiple patients saying how they would stay home all day, wait for a delivery, it wouldn't come, couldn't contact a human being when they called the office. So these were all documented. Lack of portables they could manage, lack of high flow, not enough tanks for actually activity outside the home, and et cetera. So one of the analyses we did, we broke down, did it make a difference in some outcomes, whether or not the patient said, yes, I have problems with oxygen? And we found that on that first line, that healthcare utilization had a significant difference between the patients who had problems and who didn't. So if the patients reported that they did have a problem, which 57% did, there was a statistically significant difference between patients who did not report problems. So if you didn't have a problem with your oxygen, you were less likely to be hospitalized in the past year. And the same applied to emergency room admissions. Interestingly, pulmonary rehab didn't particularly make a difference, but the education did have a significant difference. If you were educated, you can see if you were educated by healthcare personnel, the number of patients with problems was 43%, whereas if you did not receive your education from healthcare personnel, 57% of those patients reported problems. And clearly, if you had no education, the difference was even more dramatic, with 64% saying yes, they had problems. We did find out that 70% of the patients were being educated by the truck driver. So that was, and it was better than nothing, and you can see there that it was it didn't make a difference either way. But it was clear who was giving the education could make an impact on that patient's health experience and healthcare quality. So once we identified the data that got published, it was very clear we had an issue. So then it was really going to see who are the stakeholders that we had to get to make a difference. And Kathy Lindell is, I think, here today. And I were on the Hill This was at one of the ATS meetings. They had a Hill Day on Oxygen, and that's Gary Ewert, who's our head of the healthcare policy group at ATS, and Lynn Reinke, who's another well-known pulmonary nurse researcher. And that's very important. Now, I'll tell you, when I go to the Hill, which was somewhere I'd never been, it's pretty much like a foreign country. I don't know if any of you have been there. The acronyms, the lingo, it's like you're listening to a foreign language. But there are some key things I had to learn quickly. So we understood if we were going to determine how we were going to approach this, we had to include what the patients needed. We needed to identify what the clinicians viewed as the barriers for them to provide quality oxygen to their patients. We needed to talk to the DME suppliers because, you know, they're no longer, we complained a lot about our suppliers, but we had to understand where they were coming from. We had to stand in their shoes a little bit and see what they were dealing with in terms of their financial barriers to delivering us to our patients. And the payers, we actually had to listen to Medicare. And I'm not going to comment a lot about Medi-Cal and Medicaid or private, but we have this approach that we first need to deal with the Medicare issue first, and that standard, once set, will hopefully trickle down to other insurance models. So this was, I think, really kind of a turning point. This was, I think, 2018. This was our American Thoracic Society workshop. So this was a home oxygen, optimizing home oxygen therapy workshop. So the way this mechanism works with ATS is that you can submit a proposal in the summer, and you can submit a proposal to be funded by ATS as a full-day workshop, or a clinical practice guideline, or a research policy statement. You assemble your committee members, you submit the proposal. It's fairly competitive, and then ATS will select the winners, and you get funded they will provide a full-day conference during the ATS international meeting. We typically arrive a day early to do these conferences. And they provide lunch and a room and audiovisual, et cetera. So this workshop, I think, was really the first time really getting that buzz out. And this is a significant group you see in this picture. And I can't list everybody, but I can tell you we had representatives from the NIH, the FDA, Medicare, the American Thoracic Society Health Policy, and then all of the foundations. So Pulmonary Fibrosis Foundation, COPD Foundation, Pulmonary Hypertension, Alpha 1, LAM, COPD Coalition. I hate to think I'm going to miss somebody. We also had the head of LinCare was there, so we had industry represented. We had community physicians and academic physicians, nurses, respiratory therapists. I think I've covered, I had hospice there as well, represented. So this was really, to me, the first time we had a really defined collaborative effort. So this was published also. So these workshop findings, I'm sorry, to flip this around. The findings of this workshop confirmed the existence of significant barriers to optimal supplemental oxygen therapy from all stakeholders' perspectives. So what we did that day is we divided ourselves into 4 subgroups for each stakeholder: clinician, patient, researcher, and industry. And we broke out in the early afternoon, came back together after a morning of review. And then those are the writing groups. We wrote the publication up, and it was published. And this is how that group defined optimal oxygen therapy. And this print is too far away for me to read it all, but I think you can maybe see it up there. Patient education, we identified what constituted great service to those patients in terms of education, testing, what kind of equipment they should have, friendly to their environment, their daily needs. You know, there are populations, particularly pulmonary hypertension and LAM. LAM is a very rare lung disease that occurs primarily in childbearing women. And so there are young populations dealing with caring for children, et cetera, and dragging around tanks is just not an option. So equipment, travel, mobility, DME quality. What is the expectation for adequate service quality from a DME, and clinician education. So just to go through a little bit of the legislative changes in Medicare reimbursement, which is really what drove a lot of the change in service quality. That's our understanding. This is kind of the sequential. In '97, there was a Balanced Budget Act that decreased oxygen reimbursement by 25%. 2003, another Medicare Modernization Act, another decrease over 10 years. In 2004, there was a new certificate for medical necessity, and also added criteria for exercise testing. This one, the 3-tier of exercise testing was required. In 2005, additional cuts with the Deficit Reduction Act. And then this range, right around 2010 really onward, was the start of competitive bidding, which had significant ongoing reductions in reimbursement to the durable medical equipment company. So where a DME in the past might have received $250 a month per patient, for example, they now may get $125 per patient. So they have to think how they're going to survive and how they can cut costs. And that often did not include sending a driver out once a week, because one driver out is probably $40 or $50, and right away you can see that per patient amounts dwindling. So this is when we really saw a dramatic decrease in DMB reimbursement and the number of DMEs. For those of us that have been around a while, we saw many, many DMEs close, the smaller groups. So where are we? We've actually gone back about 20 years. When I did pulmonary rehab, think about those years in the, let's see, it would be the early kind of mid-1990s, 95, 6, 7, 8. We had big tanks of liquid. Patients came in with their canisters, refilled, had high flow. It was amply available. And now we are actually back to e-tanks. So this is really, it says it all. I mean, where we've really not progressed. So the next area is really how are we going to solve the problem? It actually does take an act of Congress. This can't just be done by Medicare alone. These are legislative mandates. So it actually has to go to the legislature. And again, I think I love all of you to think how at some point in this impact, and with your patients as well, is not just on oxygen, but there's many other opportunities to make an impact. And this is just one example, really, that it just kind of took off. But it really hit a nerve, I think, oxygen across so many populations. So the kinds of activities that went on, a lot of letters were drafted. Now we had a collaboration. We had the Oxygen Special Interest Group, coalitions that could sign on to these letters, and they would be sent to Congress, sent to a representative, sent to Health and Human Services, and that's what went on. So letters went out in 2018 documenting our survey and identifying that there is a problem. It's persistent and it crosses various foundations and patient populations. There was another letter to the CMS administrator regarding competitive bidding and how it had restricted liquid oxygen access and quality. And then a letter to a representative describing a patient in Hawaii, this is from our COPD coalition in Hawaii, who documented a patient had her liquid oxygen removed, just had it removed and had to be replaced with a lesser quality option. There was a call for comments. There's sometimes when legislation opens with a call for comments, and this was actually around using oxygen as a treatment for cluster headaches, which is not really applicable, but because it opens for comments, advocates and legislators are able to write in, mainly patient advocates and clinician and professional advocates, and comment on the need for oxygen reform. So this opened up an opportunity, and it was well addressed. So the types of requests that went in during this time were allowing the treatment of oxygen for COVID. Remember, you had to have a chronic condition, so we denied if it was a temporary condition. That changed, or it was asked to change. Removing in-person testing, that was really around COVID. Using a standardized dictation template, not instead of a CMN form. Removing the word home from the coverage determination title. And it takes an act of Congress to do that, and we are working on that, so unbelievable. Medicare identifies a patient on oxygen as being at home. They don't identify that that patient is out and has actually great needs to be out of the house. So the next kind of step on the ATS side that our groups, after we published the workshop findings, there was a need to have clinical practice guidelines, which had never been done for oxygen. So that was our next task. That was a very long project. It was a 2-year project. And again, we had a phenomenal group and published after a very structured review of the literature, basing recommendations on evidence only. So we could only make recommendations based on data. And what this really showed us is we're missing a lot of data. We have data on the first 2 items there, 1 and 2. We know that patients who have chronic resting hypoxemia improve their survival by using oxygen continuously for about 12 to 15 hours a day. We have strong data, even though it's old, it was well done. We do not have strong data on exertion-only hypoxemia. So we really don't have that data to state that if our patients desaturate for an hour a day, or it could be longer, intermittently, only with exertion, does that impact their survival? So we could only recommend, actually we could only suggest, because we had very low quality data, but not because the data didn't support it, it was because there wasn't available data. So that would be a hard study to do, although there are some studies underway. And I think, just as a side point, in the VA hospital, there is a general, there are some exceptions, but patients do not get oxygen prescribed for exertion-only hypoxemia. That isn't consistent across all VAs, but for the majority. So in yellow are the recommendations that came out from the guidelines that are most important to this talk, and one was they formally recommended the use of liquid oxygen for patients who use more than 3 liters per minute continuous flow and are mobile outside the home. So that ties into the legislation that we're proposing, is that we are asking for liquid oxygen to be provided and to have the DMEs subsidized for that, but only in a specific population, because not everybody needs high flow oxygen to outside the home. And the 4th bullet point is pretty, we would assume this is recommended for all, but education and training for all patients provided supplemental oxygen. But this doesn't occur. For those of us in care center networks, we have resources to provide to our patients, but we're the minority. Most ILD patients aren't seen in care center network centers. So in the community and in our patients, we call it drop shipping, and I'm sure you've all seen this. The patients order their oxygen, or it gets ordered, it's dropped off, and there's no education. So this mandate had to be included in a formal, published, peer-reviewed publication. So we can now use these publications when we go to legislatures and say, here's the evidence, and here are the formal recommendations from the experts. And this is just an example of the letters. This is just what they look like. That's all I'm showing here. This is a waiver of in-person testing. So these organizations' logos on this letter are the ones that backed this request. This is another one. Submitted a letter to support suspending of budget neutrality. This means that if we wanted to provide liquid, that CMS would require that, yes, that DME could get more reimbursement for that patient, but they were going to take away reimbursement for their other patients. So we're trying to avoid that. And so so our Oxygen Special Interest Group continues to meet every month. And now we have some good news, because this has been an effort to get the word out to legislatures. And there's many, especially the PFF, who have patients go to the Hill either virtually or in person, along with all the other advocacy groups. COPD Foundation, very active. Pulmonary Hypertension Association, very active. LAM, they are battering the Hill and the representatives with a plea and data for better oxygen services. So we finally This was around 2020 when Gary Ewert says, compared to 3 years ago, the Hill is now aware of problems as a result of patient and community efforts. So this is really a grassroots collaborative effort that was encouraging. So COVID, I don't want to say how in a positive light, but it actually helped bring attention. I mean, it was all over the news, those large liquid oxygen trucks trying to deliver to hospitals. Hospitals were running out of liquid oxygen. That's the basis for how hospitals supply their wall oxygen. Underneath those hospitals are usually large tanks of liquid. So that's how hospitals meet their oxygen needs. So it did bring attention to shortages for both inpatients and outpatients. And the PFF was actually very instrumental in providing a survey looking at patients and reported needs, and also they surveyed providers about how oxygen shortages were impacting their populations. And you see here sometimes preventing hospital discharges. There were some times they couldn't discharge patients because there was no portable oxygen available at that time. So I mentioned these Hill Days. 60 Pulmonary Fibrosis Foundation advocates, 29 states met virtually with 60 members of Congress, over 100 meetings. And this messaging is very purposefully constructed. So there's very consistent messaging. Our Oxygen Special Interest Group works very well, very closely with the American Lung Association, the PFF, American Association of Respiratory Care, and AARC, I'm missing one, but to make sure that whoever goes to the Hill messages the same emphasis, the same main points. So the legislative language that's currently drafting, in the process of being drafted, includes some key points. Removing oxygen from competitive bidding, giving CMS authority to create modality-specific payments, using payment and the consumer price index rates, other kind of cost-related requests. And this advocacy continued. PAR is a public advisory roundtable, which has patient representatives. It's a very effective group. And the COPD Foundation also, actually we had a call with the FDA to identify the problem of patients purchasing what we call non-concentrators online that are bogus concentrators or do not deliver what they claim. And sometimes when you purchase it, that site disappears. So we actually had a call with the FDA and talked with them about that. And I actually talked about that. So I would say for the past 6 months, it's just been an ongoing effort to keep delivering information to our legislators, and we've really included now patient letters. So we want to know what happens from the patient's perspective, and those patients document lapses in their care, loss of liquid, lack of mobility to get out of the house. We actually had to, at one point, Medicare insisted that because liquid was part of the competitive bidding agreement, that the DMAs had to provide it, and despite us saying to them they don't provide it, they didn't have the evidence. So we actually requested our clinicians for high-flow appropriate patients to write an order for liquid oxygen. Now the problem was that a lot of our clinicians have never seen liquid oxygen, so we had to educate them a bit. And so then we would get the actual denial from the DME. Then we redacted the patient and the DME personnel, and we sent those to Medicare. So we gathered multiple letters documenting, you say it's part of a benefit, but we're documenting that it's actually not being provided. And that was very effective as well. So this is where we are. This is the last kind of advocacy, we call it the 4 Pillars document. And this is the bill that had shopped around to find a legislative representative to support the bill. And this is what the letter looked like. So you can see multiple organizations sign on, and these are the 4 pillars. One is to ensure oxygen is patient-centric. So we're changing the word home oxygen to supplemental, and we're creating a patient bill of rights. Number 2 is to ensure access to liquid oxygen for high-flow mobile patients. 3, create a statutory service element. This is very important because Medicare reimbursement to the DME only covers supplies. It does not cover a respiratory therapist, someone to answer the phone. There's no service element, and we wanted that to change. Mainly because as soon as competitive bidding hit, most of the DMEs couldn't afford to keep a respiratory therapist on staff, and that's been a big loss. And the fourth item is establishing a national standardized documentation requirement or template to ensure predictable and adequate reimbursement and protect against fraud and abuse. And that's just trying to streamline the ordering process, which I'm not as involved in, but I know all of you are now. And I can imagine the back and forth to get those orders done. The electronic portals have helped a bit, but it's still a challenge. We sent out surveys to patients asking them to sign on. We also sent out this to clinicians. I was on the Hill with Dr. Kalaitis, who's a transplant physician at UCSF. And this was meeting with the representative, Julia Brownlee, in her office with her representatives, pitching our cause. And now we actually have identified Senator Bill Cassidy, a Republican from Louisiana, who's been agreed to take on this legislative bill. It's much easier to advocate on the Hill if you, thank you. It's not just me, this is a huge effort on many people. But it's much, when you go in and meet with these staffers, I don't know if any of you have done this, you go into the office and it's like every 15 minutes in these offices, another group is coming in, right, with their cause. I mean, you name it, they're there. And so you go in and to describe, you know, they're kind of glazed over, it's either a staffer or the representative, and you have to start with describing what oxygen is, what the problems are. Now that we have an actual bill, it will be much easier, and once that bill is out there, we'll be asking all of you to advocate, and you can actually reference a certain bill number. And the next step is to get a representative on the Democratic side, which also is very close, so we're hoping to have that person identified soon. So this is, again, all the advocacy. This is our Stanford group at the bottom in blue, walking for the PFF walk a couple of years ago. That was our gathering at lunch. These are some PFF meetings on the Hill. And you can, encourage your patients, and they don't have to go there. And you can encourage them to go to their local town halls. You can do this all virtually. So nurses are in a very unique, and respiratory therapists and others of you that are in here, but nurses are in a unique position to take this on because we are there at the bedside, in the clinic, discussing this with patients and families. So I went to the American Academy of Nursing, which is a very large national body of really a policy-driven nursing association. And just some examples of what some of these nurses did. One nurse successfully advocated for insurance reimbursement for rape kits. Now this sounds out of the blue, but she was an ER nurse and had no instruction on this, and patients wouldn't come to the ER in this position because there was no reimbursement. And so she took on the state reimbursement system and got this passed, and they have noticed a marked increase in women who will now come in to be seen because it's a reimbursable visit. And the second was an advanced practice nurse who actually, and I forget where she was, documented that her primary care services and outcomes were similar for that of primary care providers and advanced practice nurses, and successfully got a reimbursement code. And the third was a nurse who informed and advocated for the care of incarcerated persons as inpatients and developed national guidelines to commit to care equity. So it's pretty amazing what nurses can do, and it always starts with something that strikes a nerve in you. So I would just keep that in mind when you have nothing else to do during your workday, right? But it does really come along. So it's been a long path, but thanks to some incredibly dedicated patients and foundations. I mean, some of these foundations have full-time paid lobbyists in Washington, and some have none. So it really took everybody to get together to do this and push it forward. So I will hopefully have continued news, and we'll keep you posted. If we want it now, this is true. So thank you very much. I think there's time for questions.
Susan, thank you so much for sharing with us and for sharing how we can all kind of follow your path and make changes too. And we appreciate all the work you've done for patients. So we're going to open it up. If anybody has questions for Susan, we have some time for Q&A before we close everything out for the day.
And I would say if any of you have oxygen tips to share, and I'm looking at my our ILD nurse over there, Iman, for the group, because I think this is something I hear sometimes stories and solutions that would never have occurred to me. So I think this would also be a sharing session about dealing with the strain of getting that oxygen to your patients. So any tips for others I think would be great.
Hi, Susan. Thank you for everything you do regarding this. I have a question. I know someone mentioned for patients who need over 10 liters who are waiting for a transplant. Some of our patients aren't eligible for a transplant, but they don't want to go the hospice route. And I am, on a monthly basis, having an increasingly harder time trying to get more than 10 liters. And, you know, I'll have one company say, oh, we're not allowed to Y a 10 and a 5 together, and then another one can, but then it's not in the area where the patient is, and then there's nobody in there. Do you have any suggestions for these patients?
We'll start off with an easy one, right?
No, I mean, this is the holy grail, right? The patient who needs over 10 liters and they're not a transplant candidate, and and maybe they might want to leave the house on occasion. So we do the same thing. Patients Y together concentrators. Of course, Medicare won't pay for usually more than one concentrator, so there's a lot of out-of-pocket. I didn't address that, but there's a lot of studies going on looking at how much out-of-pocket cost patients are assuming for themselves. You know, the only thing I'd say about hospice, it's underutilized, and I know it's obviously it doesn't pertain to all patients, but if you have a patient who is at a point where the goals of care have changed and maybe they won't be on taking antifibrotics, is a subgroup of patients, I would encourage them to use hospice so they can get high flow, be comfortable, be moving around the house, maybe leave the house, although I don't think hospice provides portable like that. But other than that, I would say this is a challenge. So the answer is, unless you're carrying around, I didn't have a picture of that, but multiple E-tanks, but even then, with the regulators that are going to go up, no, there's no great solution, I would say. But I'm opening it to anybody else who has a tip for that one. Oximizer cannulas, a little bit help, high flow cannulas. We don't usually use a rebreather mask for patient, but that's something to think about. Anyway, sorry for not the great answer. Liquid, we need liquid.
Hi, I don't really have a question. I'm over here, I'm sorry. Turn the other way. Hello.
Sorry.
I'm like the lights are like blinding. I know, you can't see.
Thank you.
It's more of a tip than it is a question. You had said share some of the tips. So what I have done in our state for our hospital at Henry Ford is get to know who is the contact person who does travel oxygen, and then who is the respiratory therapist, because they do have them in the DME companies, because somebody has to really look at these orders and make sure that they are appropriate from a respiratory standpoint. So what I've done is started working with them directly for each of the companies that I do most of our oxygen ordering from. So there's like 5 of them. And what I did find on one tip once, we had a patient that lived in the upper part of Michigan and moved down to the southeast side where I am located. And because of the gap in between coverage and having to get a new provider, the company that I mainly work with provided 2 years of service to this patient free of cost until they got through that donut hole. And they are still currently getting their oxygen with no complaints. So it's great customer service, but it's also getting ideas, because most of the DME companies are just as frustrated as we are, I'm finding, because they're not getting reimbursed. Their billers are a pain in the butt. If anybody has to work with them, you know this already. Because they want the I's dotted and the T's crossed. And all they're caring about is making sure that that company stays solvent so that they can continue to have a job, which we all can appreciate. But it goes deeper. Our patients are the ones that are suffering. The liquid oxygen disappearing throughout the country has really impacted our patients getting out that door. So it's something that's kind of like near and dear to my heart. I wish I can come up with an answer, and if anybody has any, to get this spearheaded back again so that it's availability for our patients, but it's also at least gets reimbursed by Medicare and the insurance companies to bring it back.
Yeah, yeah.
No, please.
I think that is one of the tips I think I heard in there was having that contact person you can kind of get to know at each DME, who's your embedded, person that you can kind of count on and run by a difficult situation. It's not every patient that has these unique needs, but they're becoming more common. It is really nice to be able to have that established rapport with a couple of the DMEs, which can help the patient in the end. Yeah.
Susan, you had mentioned that you had gone to the FDA for those concentrators that we all know come without barcodes and unfortunately don't deliver anything. I encounter very frequently patients who go on commercial approved websites and they're not properly educated in the difference between pulse and continuous. And they're sold many different things. Is there anything coming down the pipeline to control that? Because at the end of I actually cold call them and pretend to be a patient or family member, and I get all sorts of different information. So what can we do about that?
So thank you for bringing that up, because on that same phone call, actually the purpose of the phone call was twofold. There is a foundation that's run by Mary Kitlowski, and I have to credit her. She runs Running on Air, and it's a primary ciliary dyskinesia group, which is you're born with an abnormality in your cilia, so you can imagine the consequences of that. And she was a runner and ran with oxygen. Anyway, make a long story short, she is on our special interest group and is persevered with the FDA, and she developed a wonderful handout very well articulating the differences in pulse and continuous flow, and itemized for each commercial model of a POC what their actual delivery was in liters per minute. So a setting of 6, universally across all POCs, will rarely get above 1 or 2 liters per minute. So on the same FDA call, I was on the call, Mike Hess, who's a COPD foundation, who has really pushed the non-centrator issue, and Mary Kitlowski, who had pushed this, and then a patient of ours from Stanford who was recently diagnosed with IPF, who had a PhD in health economics, and his wife was a nurse, an ex-nurse, and they couldn't understand what oxygen they were getting delivered. So the first conversation was all about deceiving marketing by POC companies around liters per minute versus setting. And she had copied from websites and conversations. She actually had some emails from these companies saying, oh yes, 6 equals 6 liters per minute. So we enlightened the FDA about, this was, I forget specifically which group it was, I have to think about that, a device group. So we did have that call and gave them all the data on those 2 issues. And then Mary, they say, we're gonna get back to you. Boy, they hadn't gotten back. Mary's right on them. Great to talk to you. Wait, would love to follow up. What's the next step? And one of the next steps that came up is we will talk to the FTC, the Federal Trade Committee, because evidently they have some oversight on marketing of devices as well. So we are, not we, but our group is a collective, and particularly Mary on the deceiving marketing around POC, because that's a whole nother topic. Patients and clinicians are very confused, and the marketing is misleading. So we're trying to attack the marketing to educate. I actually sat in at ATS in one of those, it's like a mini little talk by one of the commercial companies of a POC, and in the talk was deceiving to clinicians. And I went up afterwards and kind of clarified a few things. But, yeah.